Hello.
Practice is the price of mastery, and when done over and over, becomes a new habit of thought and performance. Echoing the words of Brian Tracy, I wish a very good morning to everyone gathered here. My name is Dr. Ishan Mukherjee, Assistant Professor in the Department of Public Health Dentistry, and I shall be your host for the day's program. Respected Principal Sir, Professor Dr. Jayanta Bhattacharya, Professor Dr. R.D. Regre, IDA President, IDA West Bengal State Branch, Dr. Rashid Kumar Pal, Immediate Past President, IDA West Bengal State Branch, Dr. Amol Kumar Chakraborty, President-elect, IDA West Bengal State Branch, Dr. Raju Bishwas, Honorary Secretary, IDA West Bengal State Branch, Dr. Sudarshana Mukherjee, Continuing Dental Education Chairperson, IDA West Bengal State Branch, our esteemed speaker for the day's program, Dr. Nikhil Bahuguna, Dr. Debshankar Bollav, CDH Chairperson, IDA West Bengal State Branch, Dr. Anand Pal Singh Sir, Dr. Prabjeet Singh Sethi, Dr. Harleen Kaur Sethi, Professor Dr. Soumitra Ghosh, Hospital Superintendent, Professor Dr. Shantanu Sen Roy, Program Coordinator, Mrs. Anonna Mukhopadhyay, Administrative Officer, Department Heads, distinguished office bearers and members of IDA West Bengal State Branch, faculty members, delegates, postgraduate trainees, interns, and undergraduates. We are gathered here today for a lecture and hands-on session on bioesthetic and biomimetic restorations, which has been made possible by the joint collaborative effort between Guru Nanak Institute of Dental Sciences and Research, Kolkata, and Indian Dental Association, West Bengal State Branch. I request a round of applause, please. Thank you. I take this opportunity to acknowledge the support of Indian Academy of Aesthetic and Cosmetic Dentistry and our workshop partners, Good Guys Ventures, Ergonoptics, Dentapreg, Fibrafil, and Edelweiss. I request another round of applause, please. Thank you. I now invite respected Principal, Professor Dr. Jayanta Bhattacharya to kindly come up on the dais, sir. Thank you, sir. I now request Professor Dr. R.D. Regre, President, IDA West Bengal State Branch, to kindly come up on the dais. I request Principal Sir and Professor Dr. Moushumi Pal, Head Department of Oral and Maxillofacial Pathology, to kindly honor President Sir with a token of our appreciation. Round of applause, please. Thank you, sir. Thank you, ma'am. I now request Dr. Rashid Kumar Pal, Immediate Past President, IDA West Bengal State Branch, to kindly come up on the dais. I request Professor Dr. Abhijit Chakraborty, Head, Department of Periodontics, and Professor Dr. Soumitra Ghosh, Hospital Superintendent, to kindly felicitate Sir with a token of our appreciation. Thank you, sir. I now request Dr. Raju Biswas, Honorary Secretary, IDA West Bengal State Branch, to kindly come up on the dais. I request Professor Dr. Paromita Mojumdar, Head, Department of Conservative Dentistry and Endodontics, and Professor Dr. Shomiran Das, Head, Department of Prosthodontics, to kindly honor sir with a token of our appreciation. Thank you, ma'am. Thank you, sir. I request Dr. Sudarshana Mukherjee, Continuing Dental Education Chairperson, IDA West Bengal State Branch, to kindly come up on the dais. I request Professor Dr. Shabnam Zahir, Head, Department of Pedodontics, and Professor Dr. Shantanu Sen Roy, Head, Department of Public Health Dentistry, to kindly felicitate ma'am. Now, with great pleasure, I invite our esteemed guest speaker, Dr. Nikhil Bahuguna, to kindly come up on the dais. I request our distinguished dignitaries on the dais to felicitate our guest speaker. A big round of applause, please. Thank you, sir. Thank you, madam. I now request respected Principal GNI DSR, Professor Dr. Jayanta Bhattacharya, to kindly come up and welcome the gathering. Sir.
Respected dignitaries, my esteemed registered delegates who have come here for this program, all the faculty members, students, dear friends, office staff, all the dignitaries of Indian Dental Association West Bengal State Branch who have come here today. So a very good morning and a very warm welcome to all of you. It is with immense pleasure and great humility that I stand before you today as a principal of GNI DSR to extend our heartfelt greetings and to express our gratitude for your presence here at this prestigious gathering. I welcome our honorable speaker for the day, Dr. Nikhil Bahuguna. Thank you so much, traveling all the way from Noida, Delhi, to be here with us today in this institution. The President of IDA West Bengal, my dear senior, Dr. Rekhre sir. Thank you so much, sir, for coming. We couldn't get your presence last when we had a program here in the college, but thank you so much for making your time and coming to our institution. Our past President, Professor Dr. Ashit Pal, Sir, thank you again for gracing this college and coming to your institution. I think that you belong more to GNIDSR than anyone else in our fraternity. My dear brother, Dr. Raju Vishwas, thank you so much. As a secretary, he has always been a well-wisher for this institution, for JIS Group, and for every program, whatever way we all seek the guidance of Dr. Raju Vishwas. Thank you so much for coming to this college. Thanks to Dr. Sudarshana, the chairperson of the Continuing Dental Education, the dignitaries who are sitting in front of me, my dear student, Dr. Dev Shankar. Dev Shankar's number is still stored in my phone as the CR, the class representative, way back. So Dr. Dev Shankar, Dr. Prabhajit Singh Sethi, thank you for coming to the institution along with your wife. Thank you so much, my dear friend. And there's a common bond between us, Dr. Anandpal Singh, myself, and Dr. Prabhajit Singh Sethi. We are from the same school. So they are my juniors, but definitely it's always a nice bonding to have them here in front of us. So thank you. Thanks to the partners of this program, the support partner as well as the workshop partner. I think they are here with us today. And all the faculty members, all the esteemed guests who have come from far and wide for this particular program, I welcome you on behalf of JIS Group and our institution. I have usually not taken recourse to a written speech, but this time it is something which is a great honor for us because there are so many external participants who have come who do not know much about our college. So hosting this event is both an honor and a privilege for GNIDSR. We consider it a celebration not just of dental science, but of collaboration, shared vision, and mutual commitment to excellence in our profession. So all faculty members and students have benefited immensely through these platforms from being. And I take this opportunity, Dr. Raju, to share one very personal note. Way back in 2020, when we were struck with COVID, I was really pleasantly surprised that the first box containing sanitizers, something which was extremely rare at that point of time, a box full of gloves and masks, was none other to reach this college than from Raju Vishwas. So please, a big round of applause for him. He has always stood by this institution and for dentistry. And of course, I myself, I have been multiple times invited as a speaker to the dental show held in Kolkata, to the first biennial conference which was held in 2022. And many of the faculty members here have been given the opportunity to the national podium thanks to IDA West Bengal State Branch. And over the past so many years, I mean, this college was established 2003. I was speaking to the speaker. You are here in the first NAC A accredited institution of West Bengal, a college which is NIRF ranked in 2022. So we have actively endeavored to build a meaningful bridge with all dental specialty associations across the country, consistently opened the doors under the leadership of our Managing Director Sardar Taranjit Singh, be it as a venue or as sponsorship from GIS for both state and national conferences. And these collaborations are not just logistical contributions, but symbolic of our deep respect and support for each specialty and its mission. And may I share here, because a few weeks back, I went to our respected MD sir with a proposal that we need so good students from our institution. One has stopped the institution national importance examination, and I wanted to felicitate them in the institution along with Dr. Shubhra Nondi, the first person after 6 long decades who has graced and reached to the post of IDA head office as the president. So sir was immensely impressed with our proposal, immediately said that please go ahead with this program, and also asked me that is this the only program that you are doing, or has it in the past anything has been done from GIS? And with your permission, I would just like that sir wanted everyone to know that GIS stands by dentistry, because I won't read out the entire thing. So 2009, the IDA West Bengal State Conference was held in this very institution at GNIDSR. 2017, the Indian Society of Periodontology, they had their national conference. JIS Group was one of the partners with them. Masterclass AOMSI 2018, National Integrated Typhodont Workshop at GNIDSR. Even West Bengal State Dental Council, where Raju was the member, we had on 30th of October a program here on waste management. I still remember Raju coming down. Special Olympics Bharat, Assistant Clinical Director Program, GNIDSR, AOCMF, Management of Facial Trauma, which was an international gathering, 24th to 25th of February 2023. Participants of Nepal and Bangladesh here at Guru Nanak Dental College. 38th IACDE, National Conference of Conservative Dentistry, Platinum Partner, JIS Group. 51st IDA Conference, IPS Conference, I'm sorry, I beg your pardon. Someone reached out to our head office, our MD sir immediately called me. The conference was from 8th of December, I think sir called me around middle of November. We were approaching the conference and sir said, please see to it that we extend our maximum possible help to my society, Indian Prosthodontic Society. The conference held in Goa. JIS Group was a technology partner. 23rd ISP, Indian Society of Periodontology. The convention was just held at Bishu Bangla 2025. JIS has supported this in the way that it is possible. Every year I have the AOMSI fellowship program as a venue at GNIDSR. ISPPD approaches us, we are always ready. So if any specialty organization approaches us, we are always, as per the direction of our MD sir, he always wants that we should have a collaborative approach. And may I share with due humbleness that when this program was held, I saw the first flyer. I immediately requested Shantanu that please can you put in a word that since we are an accredited institution, we have to show our programs also. Can we have the word in association with or in collaboration with? After an initial hesitation, I put that word to Dr. Raju Vishwas. It took him 5 minutes to say that it is done. So that is the level of collaboration between the JIS group and GNIDSR. We carry on this heritage, we would carry on this legacy for as long as possible. I have been at the helm of affairs now for the 8th year, and always we have tried our level best, thanks to MD sir, Sardar Taranjit Singh, who always wanted this college to be a beacon of light in dentistry in the entire nation. So thank you once again for all of you for gracing this college. And I hope we have an enriching program on bioaesthetics and biomimetics, because that is the need of the day. And you all go back learning something new from this program today. Going back, have a passion, have a desire to learn more, because a single day's program maybe will ignite the spark in you to learn more about the subject, to imbibe more about the expertise from such a wonderful person who has traveled all the way from Noida to be here in the college today. So thank you so much once again on behalf of our group, and hope we have a very fruitful program.
Thank you, sir. I now request Professor Dr. R.D. Dekre, President, IDA West Bengal State Branch, to kindly say a few words.
Thank you. Good morning, everyone. Dignitaries on the dais and off the dais. I have to make one special mention here today when I was welcomed on stage. And I was indeed fortunate to be welcomed by Dr. Moushami Pal. We call her fondly Moushami. And well, it's with her achievements that she has throughout her career, it's always an honor to be greeted by you. Thank you, Moushami. I will still call you Moushami. And Joyant, of course, 1 year my junior. So we have a CDE program over here. And every time I come to a CDE program, I'm reminded of a song by Simon and Garfunkel, which is called The Sounds of Silence. And this is entirely for the students and advice for you. The song says people speaking without talking. And it goes on like that. People hearing without listening. So today when you attend a CDE program, please study and learn. Do not study and not learn. By which I mean that you have to listen to the concepts which are being explained to you, and then you are more enriched than anything else. So before going on for too long, I hand over the stage to Dr. Bahuguna. All yours, sir. Thank you.
Thank you, sir. Now, with great pleasure, I announce that we have been joined by Dr. Amol Kumar Chakraborty, President-elect, IDA West Bengal State Branch. I request Dr. Shomiran Ghosh, Professor, Department of Oral and Maxillofacial Surgery, and Professor Dr. Kaushik Dotto, Head, Department of Oral Medicine and Radiology, to kindly felicitate, sir. Thank you, sir. I now request Dr. Ashit Kumar Pal, immediate past president, IDA West Bengal State Branch, to kindly say a few words.
Good morning and respected dignitaries on the dais. I welcome you all, the CD program organized by this institution and our IDA West Bengal State Branch. Today is Dr. Bahuguna's day, so we will hear from him only. Okay, thank you very much. We are very eager to hear from him only. Thank you.
Thank you, sir. I now request Dr. Amol Kumar Chakraborty, President-elect, IDA West Bengal State Branch, to kindly say a few words.
Welcome everybody, dignitaries on the dais and of the dais and the participants. This is another learning session and IDA is trying and giving their best effort. And our CD chairman Sudarshana Mukherjee is working throughout the year to arrange the programs, finding the good speakers, and I welcome specially Dr. Nikhil Bahuguna for his presentation today. And these programs are arranged due to keep us updated with the newer things in the profession. Everything is a changing scenario. Everything is changing. New materials, new technologies, new application of materials and technologies in the patient's mouth and clinical application like that. So I think our learned speaker will give a nice speech and hands-on, so and will be benefited, all of us will be benefited from this CD. And with that, I don't want to waste time. Thank you. Thank you all. Thank you, Dr. Bahuguna.
Thank you, sir. I now request Dr. Raju Biswas, Honorary Secretary, IDA West Bengal State Branch, to kindly say a few words.
Thank you, Ishan. It's my proud privilege that I was associated with his father's chambers, the oldest dental clinic in our state, and has a very good familial relation with Ishan and his entire family. Again, after a hiatus of 10 to 15 days, we are here for another purpose, and today's purpose is learning from Dr. Nikhil Bahuguna, my very good friend, and we have a very good relation since last several years. My gratitude to Gnidsr, especially our principal sir, superintendent sir, entire faculty, PGT, students and their entire staff. The cordial relation between Gnidsr and IDA is established since last 15 to 20 years, and now it's in the peak. My gratitude to MD sir of this GIS group and director of this institute, Simarpreet. We have a very good relation In fact, if I am not wrong, every month we meet together, means myself and Mr. Taranjit Singh, over a cup of tea, either in his office or in his residence, with a homely atmosphere and lot of discussions regarding how we can combine together, how we can flourish more our profession. And he is really a visionary person. For that reason, the first private dental college established in 2003 as Guru Nanak Institute of Dental Sciences and Research. Principal and superintendent and their entire team throughout the year maintain a very good relation with us, and so many programs we are conducting throughout the year. Our principal sir forgot to mention one another big program, which I think in the pre-conference course of 73rd Indian Dental Conference, Dr. Komal and Dr. Apurva was here, and it was a huge success program. And it's a long demand program from GNIDSR. In long run, we will surely continue this effort, and lot of CD will be took place in this institute, and we are also planning for a midterm or annual conference here. We will sit together and we will discuss, and you all are happy to know that in last 10 days, this is the third program IDA is organized. One in Doctor's Day, the topic was oral submucous fibrosis by Professor Dr. Jayanto Chattopadhyay, principal of another institute in our state. On 2nd July, our speaker was none other than Professor Dr. S.G. Damlesar, and that program was full house program on the weekdays. Today is the first day of this week, and in Monday, and the rainful weather, it's a packed house, and so many participants still on the way. They will come in due time. So this program only can done by IDA West Bengal State Branch, because the team of IDA West Bengal State Branch is so active. I am just a part of it. All my president-elect, past president, city convener, those who are in the dais, and of the dais, our treasurer, the main person behind the fund, because majority program organized by IDA West Bengal State Branch is free of cost, and total expenses he has to maintain throughout the year. Our CDI chairperson is here, other dignitaries from outside this institute also here. And lastly, I want to thank again my friend Dr. Nikhil for his valuable presence to learn all of us. Thank you all. Long live IDA.
Thank you, sir. I now request Dr. Sudarshana Mukherjee, Continuing Dental Education Chairperson, IDA West Bengal State Branch, to kindly say a few words.
Good morning to you all the dignitaries on the dais, off the dais. Just now our secretary mentioned our treasurer, and today's program is possible because of him, because all of a sudden, I would say around 15-20 days back, he suddenly said that Dr. Bahuguna is going to be in town, so let us plan something. And since Sir has a very packed schedule, we didn't even have an iota of an idea that we will actually be having Sir over here, we'll be actually be able to collaborate with him. Thank you very much, Sir. It's a pleasure listening to you, and we are looking forward to a day packed with knowledge and some new information about this unique material. And I would also like to thank GNIDSR, the principal, sir, and I hope that in future we will be able to collaborate with this college, with this institute again. Thank you.
Thank you, madam. With this, we come to an end to our inauguration. I request our distinguished dignitaries on the dais to kindly take their seats off the dais. of the Indian Academy of Aesthetic and Cosmetic Dentistry and holds the distinction of being a certified master trainer at the Smilist Academy, Hungary, a certified instructor of Malifer, Lightspeed, and Edelweiss, Austria, a key opinion leader at Edelweiss, Dentsply Sirona, Pulp Dent, and Dentapreg. As the chief dentist of his enterprise, Dr. Nikhil Bahuguna has been demystifying smiles since 2004, and this also happens to be the name of his clinic. Last but not the least, Sir is also the founder and head resource faculty at EduArt, Delhi. Please put your hands together in welcoming our esteemed guest speaker, Dr. Nikhil Bahuguna. The stage is yours, sir.
Hello, check. Hello.
Hello. Yeah. Good morning, everyone. Let me just start with greeting you all. A lot of good things have been spoken today, so I would not take more time. But yes, I'm really thankful to the Institute for having me here. A big thanks to Dr. Raju Biswas and the entire team of the IDA West Bengal State Branch, because this is not the first time we've tried to collaborate and come here. He's asked me a couple of times, and every time I've felt bad. I had to say sorry because the time permitting or schedules are not such, but it had to happen under his guidance, so it happened. So I'm happy that this time I'm here and he's sitting right in front of me. And yes, as Dr. Sudarshana said, the guy instrumental to getting me here today is Honorable Treasurer of your IDA West Bengal branch, Dr. Anand Pal Singh. Is a very good friend. We have a lot of common things that we do. And when we told that we are here for a couple of days, the first thing was, why not collaborate and do something, which I'm very happy about. That I had the opportunity to come to this glorious institute, meet principals, met a lot of seniors who actually have been inspiring generations. So all in all, it's a very happy day. So let's start. Just a small tradition. I start with the blessings of the Lord Almighty. Thank you, Doxa, for introducing me so very well. I mean, you've used very nice adjectives. I'll make sure next time I add them in my CV too. So probably I'll have to get a lot of vocabulary training. But yes, when I introduce myself, I always say, if I can't do that, no one can do it better. The only thing I say in my introduction is, I'm a dentist and I'm a very happy dentist. I enjoy the space I live in. When I say I live, my clinic, my practice, what I do is my life. I enjoy my work. And I have no regrets whatsoever telling you that it's been more than 2 decades I've been practicing dentistry. And there is not even an ounce of a regret that why am I a dentist today. In fact, I enjoy this profession. If not for this, honestly, I would have been a very stressed person. I do hold a keen interest in upgrading myself. My journey started after my MDS. I never tell people that till you're in the institute, don't learn or don't do this. Institutes give you the best thing possible, and all they tell you is now start growing. We have given you the base and the foundation. That's what all my institutions did to me. And after that, it's up to us to upgrade or not. Like Dr. Raju just pointed out about the activities of IDA, so many institutions have collaborated with this college to do so much of education program. The crux of all this is we have to grow together. If you think I know everything and I will not share it with people, is not how you grow. So growth is always a journey which people have to share. I do have a lot of associations with researchers and manufacturers across the world, and I honestly felt happy and sad both in the morning when Principal Sir pointed out a very valid point, that everyone is talking about research outside this country. We do not want to do research within the country association with our institutes that we have. And I will not say big things, but I will leave with a promise before I go that I'll definitely have something which will be done in this institute for the students and by the students of this institute. This is my promise before I leave from this place. What collaborates, which company, which association, we'll work that out. But we will start some research, sir, because what you said really hit me hard. That we do everything across the world. I'm helping countries like Germany, Austria, France research. Why can't I come here? And especially coming to Kolkata is one of my favorite dreams. Honestly, I don't even wait for a phone call. If anyone says Kolkata, yes. Then you tell me what is to be done. So my yes is granted. Usually people end with this slide, but I like to start with this because I honestly feel how many of you will be able to tolerate me for the next 3 hours. So you need to get my gratitude before you leave or before I leave. Because for me, this is something that I do probably twice a week. For you guys, yes, to squeeze out your time on a busy day, and especially when the weather is so nice outside, to be sitting in this room for a long is a very hard job. So the first thing that we need is the audience. So I would like to thank all of you for making it happen today. The Institute for having me here today. IDA West Bengal State Branch for letting us collaborate and making this day happen. My support partners, Good Guys Ventures, who's always been very kind to help us out with the logistics, the work, how it's to be associated. My organization through which we are collaborating here today, the Indian Academy of Aesthetic and Cosmetic Dentistry. It's about 34 years old now. So we are now probably going to start seeing what midlife crisis is all about at the organizational level. But just to give you a little brief about it and why and how we plan this institutional events, we are the only organization, as in an independent organization, by the time the screen comes back, who is associated with the Asian Academy of Aesthetic Dentistry, the International Federation of Aesthetic Dentistry. When I say that, collaboration as in whatever benefits as a part of IACD I get, or an organization I get, is the one that Asian or the International Federation issues to us. So staying here in India, I have all the information happening all across the world, in Asia and the world, and how the world is progressing about it. This was me last year when I represented India as the president of the Indian Academy of Aesthetic and Cosmetic Dentistry in the Asian Academy meet, which was held in Taiwan. And it was a really proud moment to stand amongst the stalwarts of dentistry and talk about dentistry in your country. We believe in sharing knowledge, and that's the motto. Our founder president, Dr. Sandesh Maikar, always says, till you are sharing, you are young. The day you stop sharing, please retire. It's not about old or young. Just retire, because if you cannot give back to your audience, to your students, to your colleagues, then holding back knowledge is of no point. That's exactly how we live our life with. We conduct a lot of activities. We have an annual conference every year. In fact, I don't exactly remember which year, but it was 2006 or 7, we had a big event in Kolkata itself. We have zonal conventions, we have outreach events like this one today, and I'll exactly tell you what we do at the campus events. A Founders Day event, a study circles which we encourage a lot of youngsters to get together, make small 5, 6, 7 people. Even if you're not 200, it's okay. Idea of developing all these events is to start learning, start sharing, and start presenting. See, I've seen enough dentistry in the world that I know Indian dentistry is very good, but we lack in one small thing. And that small thing is research and documentation. Our clinical hands are far better than what you see with people in America and Europe. We have a lot of we have the richest patient pool in the world. I've seen institutes where on one patient they cannot do more than a procedure. And here our students get patients in bulk to learn. They do one cavity prep on one patient and that's it. You're supposed to be good after that. They work on simulators and we work on natural human beings. We have the best opportunities to learn. But When it comes to documenting and presenting, we sometimes get a little lazy. So the idea of these events is to make sure all of us start presenting a world to the world, and then maybe one day you're standing and lecturing and I'm sitting there and appreciating your work, is what we want. We have a Life Members Benefit Program where we actually extend a lot of educational activities to our life members. It's not about giving a rupee discount on a conference, but yes, special sessions by different mentors across the world, online and offline, are curated specially for our members. We also hold an accreditation program wherein, see, aesthetic dentistry and implantology, two branches in dentistry, are officially not a specialty. They are a part of merged dentistry. But we want to promote people as aesthetic dentists or functional aesthetic dentists. So our aim is to first examine you, test you. It's a 3-stage examination. You submit your cases, you have a theory examination, you have 2 practicals and a viva, then a case presentation. It's about 3 years that it takes. And then you are accredited as a member with a fellowship. We request people to share, and I would request all of you, please submit your cases if you think you have done a decent job. Get it written, get it drafted, submit to as many journals as you can. And when you reject it, do not feel bad, because every rejection is one mistake less next time. So please try and upgrade and update yourself so that we grow together. The idea of today's event, IICD at campus, is to encourage and promote a lot of talent that you already have, you've seen, you've felt, but you've not explored. So I am going to present something today that doesn't mean that that's the end of story. I want you all, and as I promised, I want you all to start from there and now take the concept of research and clinical science as a merged specialty. Do not just say, I'm doing research so I don't care about the patients, or I'm a clinician. How does research help me? It is the science which backs your art. So please make sure your science and art are blended, balanced, and then given to the world. Before I start, let me just announce we're doing a conference in November this year. Like our every year conference, it's happening in Navi Mumbai. I'll share the details with the management and principal, sir, so whoever is interested can contact. And if you are interested in this, we also have the luxury to extend the invitation to you as Indian delegation to the Asian Academy of Aesthetic Dentistry, which is happening in Malaysia in the later half of November. So anyone who's interested in coming and seeing how this branch of dentistry unfolds, we'll be more than happy to welcome you. Well, that's my family. I always have to thank them, because it's a joke around that, are you still married? Well, yes, I am. And why they joke with me is because I'm never found at home. I've been in Kolkata for the last 5 days. I go back home for 2 more days. Then again, I'm out for 3 days. So these guys are really supportive. And it's not just my family. Each one of us sitting here who leaves the house the entire day, then goes to the clinic, comes back. We need to be thankful to our support partners. Like we thanked our companies, we thank the IDA, we thank the IICD. We have to be thankful to our parents, our spouses, our friends who tolerate us every day without anything, and always whenever we go back, they're smiling. So when we talk about the topic of the day now, so the words that we chose to probably give a heading or a title were very simple: biomimetics and bioaesthetics. Because someone told me these are new branches of dentistry. But even before I tell you it's new or old, let me ask you, we remember second year of BDS in our schools? Dental school second year BDS? How many of us remember that we carved a block, a wax block? We did or we did not? At least we submitted, right? I will not ask who did, but someone submitted. And that red pencils, hematoxylin, eosine pencils, some histology we used to draw. Can someone please tell me why were we made to do that exercise? Because we don't use wax in a patient's mouth and we don't draw cavities on a patient's teeth. So why were we told that there is a cusp, there is a fossa, there is a groove? Or why were we told there's an enamel which has rods and there's a dentine which has tubules? Why was this question so many times asked to you? What is the hardest structure in the human body? And is dentine elastic or is dentine hard? These questions all of us were asked, and we probably answered it right. But that day and today, the connection got lost somewhere. And I'm not here to teach you something, I'm here to tell you your basics are what everyone is exploiting, which is the knowledge of enamel and dentine and the shape of the tooth. That's exactly what is biomimetic and bioesthetic dentistry. This is not for the front 2-3 rows. This is for the generation that derives education from social media. I'm not saying it's bad. Please see. Please observe, but do not learn. First, check whether it's validated or not. What pinches me most is when someone has a doubt, and rather than coming to your dental school teacher or your professor or your head or your principal, you post a question on Facebook. Now, that is not good. First, learn from the people who've touched tooth 10,000 times, and then someone who only types on a keyboard. I also do the same. Even today when I have a problem, I have a question, I ask humans first, than going to AI or chat boxes. So this is a disclaimer which I always put. Please rely on education through books, not through Facebook. And please, if someone is criticizing you for your work, accept it so that you have another chance to improve. The idea is not here to convince anyone, I always say this. The idea is to initiate a dialogue, a discussion. So let's talk about dentistry. Whenever I ask this question, which word do you think is the most glorious out of these four? I think there's no point discussing because this one word attracts everything. Everyone wants to be an aesthetic dentist. And how we know this, whenever I travel, I have a very bad habit of observing dental clinics very keenly who have the boards outside. People have stopped writing general dental surgeon. Even if they have written MDS, they would not mention a specialty. But every clinic, 9 out of 10 have written cosmetic dental surgeon and oral implantologist. And funny part is these two branches are not officially taught anywhere. They're part of other specialties. So I don't know why we have a problem that I cannot call myself a general dental surgeon. How many of you have heard of a gentleman, Dr. Brennemark, who found the implants for all of us? He is the man who showed us that metal could be put in the bone and teeth also. Please see and read his credentials. Outside his office, the nameplate is still there. Dr. Brennemark, Junior DDS. And this guy introduced implants to the world. We see so many names outside our practices, probably member of this association, that association. Making that list big doesn't help anyone. It can get your patient in your operatory just once. After that, what makes the patient come back again and again is the way you have performed your skill on that patient. So become skillful dentists first, and for that we need to understand what are we touching, what are we replacing, is it functioning or not, and if the mechanics of that is good. Because questions are very simple. We do a restoration on a patient's mouth. What is the first instruction we give them? Don't eat for so many hours, months, years, whatever. Don't chew on this side. Don't drink water. Can you tell them not to touch tooth to tooth? Can you tell them not to salivate? Or can you tell them, please keep your mouth open, air should go inside and dry my cement? Mechanics is something that we don't understand because biology is very poorly understood. And then all of us are looking at beautiful teeth. So a patient is smiling but losing weight because they cannot chew food. Or someone developing a jaw pain or a neck pain or a joint pain, and dentists do not understand why it's happening. And then comes, how do we replace it? With what materials? We have so many things that have evolved in dentistry in terms of material science. And the newest of them all is the art and science of giving warranties to our patient. So when I say warranties, I'm talking about those warranty cards for non-breakable dentistry. Knowing that the tooth can always break, we promise patients that my tooth will not break. In that, what is happening? The crowns are not breaking, more and more teeth are breaking. When it comes to material science, choose something which gives you a second choice, something which is repairable, something which is forgiving. Resins, for one reason, have been the biggest mainstay of dental practice for the last 30 years. But when I talk about resins, everyone says, no, I don't think it's a good material. Why? Because of one word, it shrinks. So today, my question to all of you is polymerization shrinkage a good vector of resins or a bad vector of resins? Should we be scared of it? Or should we be happy that it's shrinking? So you must be thinking this man is a little off track today. We all have been thinking for the last 40 years composites are shrinking and we are trying to reduce shrinkage in material, and he's standing and asking such foolish questions. But with all responsibility, I am giving this as an open statement. Shrinkage is not a bad vector, it's a good vector, provided we know how to handle it. First, let me tell you what is bad about it. See, we all know composites shrink, and when they shrink, they cause so many problems. Right from the simplest sensitivity to probably breakage of tooth, to cuspal flexure, to micro leakage, to everything. So that's shrinkage. You shrink, you cure a composite, it has to shrink. And this picture is universal, everyone will show you this. But there's something which I find is wrong about this picture. There's a huge bias here. And the bias here is the entire tooth is filled in one shot. You are trying to cure everything towards the core in one shot, so it will shrink. We all talk about incremental composite techniques, but what we do in our practices every day, bulk filling. And then we have problems whether it will stay or not. If I have not done it correctly, it will break. Pictures like these, patients are coming back with fractured restorations. So when you see all this, what is the first thought that a normal person sitting on the dental chair gets? If it has to break, then why not give them harder materials? So we are going from a couple of megapascals to 1000, 1200 megapascals in terms of strength. Fair enough, let's see whether this is needed or not. My idea of living life, forget dentistry, of living life is do not take stress, because whatever you're doing, you cannot predict the outcome. What has to happen will happen. So stop straining your brain and saying that, oh my God, what if it happens tomorrow? If it has to break, honestly, it will break. Our aim is to make sure we perform whatever we are doing best right now and stop telling them 5 years warranties, 10 years, 15 years, 20 years. Imagine someone giving a 5-year warranty card to a patient in March of 2020 when COVID happened. And I mean, sadly, a lot of people lost lives. But imagine a warranty card in the hand of a patient who's no more. Does it make any sense? We are not trying to give warranties to inanimate people. These are human beings walking on the road. They need to realize the wear and tear of your tooth and body. It's like a heart surgeon opening the heart and saying, now you're eternal. Now you will never die because I've done a good surgery for you. For me, when I speak dentistry, I want my dentistry to be forgiving, my dentistry to be easy, and my dentistry to be helpful to the patient. I choose materials which do not cause any further damage, because all of us, at least if you have not taken the oath, when you are graduating, you're given a piece of paper which has the oath in it, and a big crux of that is do no harm. And we'll discuss what harm we do when we promise patients abnormal dentistry. A material which is conservative, it's quite aesthetic, it's quite economical, it's quite easy, it's quite repairable, and the only material which has the potency to be bioesthetic, biomimetic, and bioactive are resins. And in human body, it's a very common, very common thing. You have a problem, let's say, in one of your eyes. Would you go to an ophthalmologist and say, remove my old eye and give me a new eye? Or let's say someone has a fracture in the hand. Break my hand, cut it into two, give me a new hand. But when it comes to teeth, we all love doing that. Oh, your tooth is broken, let me remove it and give you a new tooth. I'm not saying all teeth are savable. But if they are savable, let's try and save them. Whenever you choose a material, I mean this one glorified word, biomimetics, please think about it. What does biomimetics mean? You have to mimic nature. That means replace whatever is lost with something which mimics nature. So let's see what nature is. This is our nature. See, we are all dentists. We talk about enamel, dentine, pulp, cementum, PDL, etc. See, I cannot regrow pulp. So we're not talking about pulp today. Let's talk about the hard and soft layers of tooth, which is enamel and dentine, the crux of restorative dentistry. Now, how does a tooth behave when a tooth is under loads? Let's first see the pattern of behavior. Now, this is a tooth which is under occlusion every single day. And enamel, we all know, is brittle like glass. Enamel will show cracks, no matter what you do. And these cracks are repaired by your salivary proteins. But the pressure of these cracks, what sustains? Is the core of this dentine, the soft cushion. The chairs that you're sitting on, cushion. That's why your back is absolutely comfortable. Otherwise, if I give you a wooden plank to sit, in 5 minutes maximum, You'll just get up and leave. Then comes the design of the tooth. We all like these sharp cusps. Whenever we are restoring teeth, we want to make those sharp, beautiful cusps. We all do that. But the moment it comes to doing occlusal adaptation, what happens to that beautiful anatomy? You first touch it left, then right, then center, then a couple of brush strokes, and the tooth is flat. And now the patient says, now I'm comfortable. Did we want beautiful occlusion, beautiful anatomy, or functional occlusion? The question is trying to replicate cosmetics, and I'm not saying aesthetic. Aesthetics is natural. Cosmetics is artificial. Trying to replicate because someone posted a case on social media in which you saw a very sharp cusp. You want to replicate that. Without realizing your patient came to you with a lot of destruction means the tooth cannot take that much of load. You have to make sure that the tooth is replicated how nature made it. And nothing in nature is sharp. See anything, even there's a psychological analysis done for small babies, 0 to 6 months. And it has been proven that whenever babies look at round faces who have got soft features, they smile. If you have very sharp, very bright features, they don't like you. That's another story. Later in the life, they may appreciate sharper people more than rounder ones. But to start with, they always like round things because it's soft. We need something which is soft. The idea of mimicking dentistry is very simple. Create roundness in the tooth. And I always give this example. When you play cricket, how do you catch a ball? With a flat hand or with a cupped hand? Why do you cup your hands like this? So that the forces do not concentrate at a point, they come and they get distributed. That's why God made DJ like this. The dentino-enamel junction, is it a flat structure? It's always scalloped. So that forces are like a cricket ball, it can be absorbed. The structure of enamel, it's like a dome. It's never a flat structure, it's always like a dome because domes historically have the highest success rate in terms of not falling under loads. The pressure potential is always on the side, never on the top. And then finally coming to your dentine. Is dentine having any kind of a fiber or a softness in it? Or is dentine hard like your brittle chalk? Hard or soft? Please someone tell me this. See, my flight is at 7 o'clock. I have enough time to keep on asking questions. Until you answer, I'll be standing here. So hard or soft? Soft. Oh, who said hard? Please show me your hand. It is not hard. Dentine's basic property is viscoelasticity. Means it is viscous. Viscous means not very thick, but elastic. So that whenever the pressure of enamel falls on the dentine acts like a cushion, absorbs, replaces. Otherwise, imagine if dentine was hard, all the pressure was going to the furcation and every teeth would broke. So that is the third part. Dentine has to be reinforced with fibers because normal dentine has collagen fibers, type 1 and type 2. We all know that. So the good part is we know everything. The bad part is application was not done. Very simple question. When you want to know what is someone's choice, so if you have to ask me, what do I like in life? What is the simplest thing to do? Ask me. I'll tell you what I like in life. So when it comes to the tooth, let's ask a tooth. What does the tooth want? Does the tooth want 1200 megapascals? Does it want 20 mm of hard materials or something else? Compressive strength of human enamel is just about 384 megapascals plus minus 100. Kids have slightly higher. When you start braiding or threading, it gets a little lower. But let's say the range should be about 3 to 500. But this is only enamel, which is very thin. What about 1.5 to 2 mm? The core of the tooth is made up of dentine, and dentine cannot have compressive strength because dentine should be soft. And for dentine, you need flexural modulus, which is about 18 GPa. I am not here to teach you anything. I'm here to give you the first hint of clinical dentistry. Whenever you choose a material, ask your manufacturer this question. Does the compressive strength of your material match human enamel? And does the flexural modulus of your material match human dentine? If you have the answers close to these numbers, it's a good material. Now if someone says, my compressive strength is 1200, it won't even break if an elephant stand on it. Is it something I should buy as a lie? Because I'm buying this huge lie for the last 20 years. So we have a 5-year card, non-breakability, then we have a 10-year non-breakable card, then 15 years, then 19 years, then 21 years, now there's a lifetime guarantee. Look at the funny part, even life does not have a lifetime guarantee, but the tooth has. So sir, like if this is what is happening, we'll have probably warranty cards which will tell you, you will die, but your tooth will not die till the next birth. So why are we lying to our patients? Everything comes with a time span. Every technology has a time. It will end after that. So we cannot tell them, and that's why our patients don't come back for recalls. Have you ever wondered why every dentist is telling come back for a recall, but the patient doesn't want to come? Because just 2 minutes before that we said, 5 years, get lost, nothing is going to happen. So why will they come back to you for a recall? And if they don't see you regularly, that one tooth could be right, the other 26, 27 are getting distracted. There are two terms which I'm going to discuss very briefly. One is called filling and the other is called restoration. Are they the same? Okay, just help me with a very common word that our patients use for fillings. Putty, masala, etc. Have you ever thought, why did this word come in the practice? Kahan se aaya? Who gave this word? Would any dentist tell a patient that I am going to fill masala in your tooth? How did this term originate? Just think about it. Some patients saw one dentist taking some material and rubbing in the hand. What do you rub in your hand? You all know that. And then they saw it squeezing it, tightening it, taking it somewhere and packing it. Common patient perception was you were mixing water into some cement, making it a masala and putting it back. Did we ever question that? Now whenever a patient says, Doctor, masala bharwana, yes, please come. How many of us stood there and said, there's nothing called masala in my practice? You want a restoration, we can do it. But then we take one material, we either mix it, we roll it, we cure it. So the patient's perception is not wrong. Because patients are talking about these. And all these masalas, all these putties, all these pastes, they're falling off. Sometimes giving sensitivity, sometimes giving pain. But what does the word restoration mean? Very simple example. Let's say this wooden flooring has a crack on it. And you have to repair it. Would you repair it with wood? Or with sawdust, with mud, with plaster, with cement? What will you use to repair it? If it's wood, you would want to add wood. How difficult is that to understand? If I have lost dentine, what composite should I use to replace dentine? Something which is hard or something which is soft? If I have enamel cavities only, what should I use to replace these enamel cavities? Something which is hard. And if I have a combined cavity, my dentine should be soft, my enamel should be hard. Is it something very difficult to understand? Okay, let's talk about materials. What composites do we use? Okay, don't click this slide because this is the slide which I don't want you to practice. When we talk about which composites you use, the first answer here is companies. I use Dentsply, I use 3M, I use Ivoclar. I'm not asking which company are you using. My question is which composite. Then people say all this, Habrate, Ninofil. These are the most evolved people. I want to show off my knowledge, that I know the science behind it. Did I ask you the cluster size? Did I ask you the particle size? All this is wrong if you do not know that there is nothing called universal composite. Universal composite is the biggest myth of restorative dentistry. Let me show you what universal composites are, and especially bulk fills. I have a cavity about 8 mm deep, and you just saw how enamel cracks happen, right? And what prevents them from going to the pulp is dentine cushion. This is a universal composite. It could be any company, right from a C grade to the most expensive universal material. Let's see whether it saves your tooth or not. And any universal material, why do we buy it? Because it's easy, number one, it's polishable, number two, it's hard, number three. All the cracks are going down because they are all hard materials. And now when this happens, first thing is sensitivity to the pulp. Then the patient has pain complaints. They say hot and cold is bothering. We have done enough damage now, the tooth cannot be saved. We have to do vital pulp therapy now. Vital, non-vital, whatever, the pulp has to be removed. Why? Because I want it to be one layer restorative dentist, everything in one shot, and that's it. I'm going to introduce 3 terms. If you know already about it, very good. If you don't, just divide tooth into these 3 terms every time you have to restore. First is bio-dome. What is a dome? I just showed you a dome shape. How many of you remember the term crest of contour, which was taught to you in prosthodontics? We do remember, right? Your wax carvings your instructors used to say, Why have you made it flat? Where is the curvature? Where is the crest of contour? Why were you taught this word? Just to make it look fat and thick? No. That crest of contour is the most important thing in restorative dentistry, direct and indirect both. Till you are at the crest, your tooth is undertaking only compressive loads. And to break under compression is very difficult. Imagine this stick in my hand. If I have to push and break it, I have to be a Hulk. But if I just have to flex and break it, I can. Because after that, crest of contour starts tension. Means flexible loads. They can easily break. The second is the peripheral enamel, which is the most pristine structure. How much of enamel do we have at the periphery? 0.6, 0.7 maximum. And what is the thinnest finished line you have made probably the last evening? Or 2 days or 5 days or 10 days before? Was it 0.3? 0.2? 0.5 or 1.5? So imagine we are cutting from the top. We first destruct the biodome. Then we cut on the periphery, we destruct the bio rim. And now there's just one saving grace, poor thing, which is left, which is the bio base, which is your dentine. How do we restore it? With a hard material. So hard inside, hard outside. And now when the tooth wants to break and there's flexure, will it ever sustain these loads? Okay, honestly tell me, when your patients call you and say, Doc, the crown has fallen off. How many times it is a neat debonding? And how many times the actual tooth is inside there? Sitting right there telling you, I've gone. Now please start learning implantology. Because the tooth, again, everything is in the science of your tooth. Whenever there are loads on the tooth, your enamel will bear the load where it can. And once that's done, it leaves it to the dentine and the structure of the tooth to bear it. Now it's up to your dentine to bear it. This is your dome, which is above your contours. Now your dentine is going to bear these loads. And that's why you need a segregation of enamel and dentine. Because dentine is like that net. In fact, I always give this example, and I was so happy when I entered the institute. The first thing I pointed to Dr. Prabjit was, my life is easy today. Because the moment I entered, there were two nets tied. One lower net, above that there's a higher net. And that's exactly what I teach. You have to have these nets so that even if someone wants to jump on the net, the higher one takes all the loads. By the time you reach the lower one, loads are given off. So no one is going to touch the ground. So please, whoever is not seen, go to your entry. Please check, the base will be your furcation. The first net is your dentine, the second net is your DJ. Throw whatever you want on the top, the floor will never have the load. We go ahead, we do restorations, universal composites, bulk fills, even onlays which are made up of single unit of glass. All these things are brittle. Look at where the forces are going. And that is why they crack and break humongously. I'm not against cracks or failures. But if this is breaking and breaking the tooth into two halves is what is wrong. Now, I don't want a fracture like this. Please look at this curve. Look at the compression. It's all above the loads that are being taken. At the neck of the tooth, you only have tension. And tension is the easiest force to break anything. Even in life, if I have to make sure that I make you an unsuccessful person, I only have to give you tension. That's it. I will give you tension and leave. After even I have left, you'll still keep on thinking about it. That's how a tooth reacts. One small crack today, it will keep thinking about it. The crack will grow. And 6 months down the line, what is the fate of your tooth? It's in your dustbin. And that is why we all want to learn replacement philosophies, because all teeth are cracking and breaking. Now whoever wants can click, because the answer is not the company or the size. The answer is dentine replacement for dentine. And I'm very clearly using the word enamel layering, not enamel in bulk. Whichever restoration you're doing, you will have to replace dentine probably in 2 layers or maybe small bulks. But enamel has to go cusp by cusp. You cannot have a stamp or a bulk fill for enamel, because enamel cannot shrink. Enamel is brittle. And if brittle things shrink, they will break and crack. So the same restoration which was breaking, now you put a soft dentine as a base first, and now put a hard enamel on top, and see the difference. What is taking the loads? The segregation of enamel and dentine. So is this tooth invincible now? Maybe not. But if it has to break, let's say it has to break, I've increased the life cycle of my tooth. It's not going to break in the next 2 months, 2 years. Maybe it's going to take 10, 15, 20 years to break. And even if it's going to break, it's going to break at the crack point, not underneath. So my pulp is safe. Maybe I can repair this tooth or just replace with another onlay. I don't have to do invasive restorations on my tooth. Because this is the simple physics of tooth. You will have pressures on your tooth which compress. But what saves this? Whenever you have a compressive load, you have an alternative, leeway, if dentine is present. If dentine is not present, this compression and this tension curve will break your tooth. If dentine is present, it will subdue, push it back. Subdue, push it back. So the goal of any philosophy of dentistry is, number one, be minimally invasive, and number two is being biomimetic. Respect nature. When you say biomimetics, please respect nature. See how tooth is evolved, how the tooth was made. Whenever you're replicating, try and use the same philosophies how your tooth was created. So no sharp edges, no flat floors. Especially for composite restorations, no. And then obviously comes minimally invasive. So how many of you in this room want to be a minimally invasive dentist? Probably everyone, right? Even if you don't raise your hand, I know you want to be. But how many are actually doing minimal invasion on your tooth? How many students, people sitting in this room are using some kind of a magnification device? Like loops? You see the percentage? Till now someone was doing this, someone was doing this, now everyone is sitting like this. Okay, why are you not using it? I saw ma'am doing it, sir doing it. But why the rows behind are all looking down right now? Is loop something bad? Is going to spoil your eyes? Because this is the first lie we tell ourselves. Aankhein kharab hogi to kya karenge? Then there are people who say, I start getting headaches. Watching reels on your phone for 6 hours doesn't give you headaches. Seeing the screen 24/7 doesn't give you headaches. But seeing a tooth magnified for 30 minutes gives you headaches. Perfect, take a combi flam, it will be fine. Tell me more problems. Why don't you use loops? People find it expensive, right? Hai na, shayad. Which phone do you have, ma'am? So don't give me, at least see, if 20 years back I would have said it's expensive, agreed, because we never had phones. Today people have iPhones and Androids, you're buying a phone worth $1.5 lakh. But you do not want to invest in a loop which is 60,000-70,000 rupees. You upgrade your phone every 2 years. Forget 2 years. iPhone launches a new phone and the next one is in line. And we are also in line. But a pair of loops which is going to stay for you for the next 20 years. If you divide by per hour in those 20 years, not even 5 rupees an hour. But you would not want to buy it because someone said it's not useful. Try for yourself. And it's not the money, it's the utility it gives you. If you don't have access to magnification, you don't have access to knowledge. Okay, let's do this simple exercise. Click a selfie, forget even a nice picture, in a group of 5-6 of you. What is the first thing you will do by instinct? If it's your phone, you will magnify to see how good I am looking. Why are you bothered how good you're looking? It's a photo, it's not going to jump out of the phone and say anything. But you're still very worried, no, if I'm looking good or not. And if not, then what do? One more. But do you have this option on a tooth? I've drilled a tooth, let me click a picture, magnify, one more. That means another tooth, then another, then the third. And we keep on destructing teeth like these. All for what? We don't want to have magnifiers. I mean, magnification has evolved. Firstly, we used to have those thick metal frames, big loops. It used to be heavy on the nose. Today you have titanium frames, super light frames. You have loops like ergo. You just have to sit straight and your back, neck, everything is sorted. So no more neck ache, no more backache. And please remember, if at all you want to do this, do not do it without a light. Because if you don't have illumination, your vision is always dulled. This is the reality of dentistry. The bigger you see, the better you treat. The lesser you see, the more luckier you wished you had. When we're talking about vision, let's look at the other aspect of vision, which is how does the tooth look when it comes to us. Let's say a patient enters your practice and says, Doc, I want a veneer or a diastema closure. What is your diagnostic criteria? How did you have this gap? Do you have some habits? Is there a frenum problem? Is it tongue thrust? Do you put some stick or a toothpick in your tooth? And then we choose it. How was the bite of the patient? Can I do direct? Do I have to do a ceramic? That's all secondary. Primary is look at the health of this tooth. Take a small trans-illuminating light, shine it for 2 seconds. Please tell me, now this tooth, can I do a surface veneer on this? I will touch the crystalline structure of glass and it will break into two. Now, how many times it has happened you started drilling a tooth and middle of it, half of it chips off. Some cusp breaks. Have you informed your patient beforehand it can happen? But if I have a picture like this, I surely can tell the patient and show the patient. If this is your tooth, I am so sorry, it is not a case for a bonding or a veneer. I will have to do a full surface coverage crown. I agree that every tooth should not be cut, but this has to be. If I don't cover it 360 degrees, it's definitely going to break. This gentleman wanted tooth brightening for himself. Look at the huge crack in the center of the tooth. You put peroxide based gels and the pulp will start howling. I have to tell this patient we first need to remineralize or probably do a resin seal, then only we can brighten your teeth, otherwise we cannot. Unexplained sensitivity. My tooth is sensitive, I don't know why. I brush twice a day. I'm using Sensodyne. I don't know why people are crazy about Sensodyne. Sensodyne is just a paste. If you have a defect, Sensodyne cannot heal defects. When you transilluminate, what do you see? There's a huge underlying defect. Now this, we were taught in a very simple term, something called backward caries. Where caries starts as a very small pit but goes like a cone. The better version to this is occlusal effect caries. When patients, remember how the cracks were happening in that animation? Every patient will have that crack. Unlucky ones, bacteria will travel through and get submerged into your dentine. And this is what they cause, internal caries. And now when the patient is having sensitivity, surface is absolutely clean. How will you convince this patient that you need a restoration? If I cannot show this to my patient, I'm sorry, I cannot convince them. Doc, I have sensitivity to sweet food only when I have something sweet. Very classical indication, dentine is exposed. But when I transilluminate this tooth, please check the magnitude of crack. Is it a small crack or a through and through mesiodistal crack? So what is my plan for this patient? I do not know. I can do a direct restoration, an onlay, overlay or a crown. But before any of that, what do I have to tell my patient? If I touch your tooth, there's a high possibility the cusp can fracture. I may end up doing a root canal, post-core and a crown. If you're ready for that, only then I'll touch this tooth. Else, leave it as it is. So a lot of people tell me, how can you be so harsh to your patient telling this tooth can break? So please go and read the consent that we give before a general anesthesia. You know one of the points, what does it read? Anything can happen, you can die on the table. It's called death on table, DOT. And we sign it. You're signing death warrants, but you cannot sign and give it to your patient, the tooth can break. Just have to be a little vocal and you have to be aware of what can happen. These lights, they're not just doing crack detection, they also tell you biofilms. They also show you whether your bonding surface, your clean surface is there or not. A lot of patients come with unexplained periodontal diseases, many a times. And we do scaling, polishing, it's not helping. Every 3 months, they have a similar kind of deposition, similar pocket formation. It's the biofilm which is invisible to our eyes. We have cleaners for that. But first we have to identify it's there or not. Then comes one of the biggest, I would say the funniest aspects of bonded dentistry. Now we all started learning tooth preparation for which material? The first material introduced to everyone in a dental school is? Absolutely. And what are the dimensions given to us? You have to breeze the DEJ because amalgam has to go and touch a elastic layer. You have to create walls which are inverted so that it doesn't pop out. You have to give it very, very flat floor so that there is no stress concentration. If it's a class 2, make a line angle, point angle, your cavity has to go out of the contact area. Totally agree. But for a mechanically retained restoration. Now the shift happened from mechanically retained to bondable. But did we shift in cavity shapes? That's why I called it the biggest villain. This one word, somehow I feel it was given to scare all of us. Don't do composites. The number of walls you have bonded to unbonded is C factor, and higher the C factor, more the shrinkage. The moment you put composite, it is bound to shrink. So let me first tell you what happens. Whenever it shrinks, the toughest is a class 1 cavity. Because here you have all bonded surfaces. And the easiest is a veneer, if you're doing a surface veneer. Because that only has one bonded surface. But the more bonded surfaces you have, the more chances of shrinkage at each surface. And that's why people blame composites for sensitivity. This, forget you're a BDS graduate or an MDS graduate, everyone who's cleared 4th year BDS will remember this. When you were giving your cons in endo exam, you had to find a class 2 cavity, right? So which kind of cavities were the ideal ones, those huge big boxes or the initial class 2 cavity? See, something like this, initial cavity. What should be a preparation for that tooth? Remove what is needed. But let's go back to final year BDS and also final year MDS. When we had to do onlay preps, what design did we make? So let's go back one design. Here I have a tooth in which I have cut very little enamel. I have enamel from all the way top to bottom and from this aspect to this aspect, holding the tooth internally. So now when is pressure on this tooth, will the tooth flex outwards or inwards? So much of internal splinting. What is happening? The pressure will make the tooth flex inwards. Now we cut the ridges which are joining the front to back side. Now when there is pressure on the tooth, how will it flex? And that's what cracks and breaks teeth. Very simple. So for me at least, when I'm doing bonded dentistry, you do not have to extend to prevent. Look at this cavity here. You have a mesoocclusal defect, so we do an MO cavity. There's a disto-occlusal, we do DO cavity. There's a central pit, we drill the central pit. What have we saved? The crossing ridges on these two sides. So whenever the load will try and separate these two halves, natural dentition will try and pull it back and hold it. The idea of saving teeth for a longer time is to retain as much of nature as possible. Once you've done the cavity preps, then comes the second aspect, which is known as residual decay. So there are two terms which we all know, which we have been exposed to. One is called affected dentine, one is called, very good. Which one do you leave and which one do you remove? Very good, very nice. We're all here, till here everyone is going perfect. How do you differentiate between affected and infected? So the one which is soft and scrapable is infected, one which is hard and non-scrapable is affected. Anything else? Color? So which one is affected? Dark brown or light yellow? The dark one is affected, the light one is infected. How many of us are actually, again I would ask, wearing loops? None. What colored light do you have on your chair? Orange. Are you seeing the tooth in a shadow or an illuminated area? Shadow. And can you actually read color? The statistics of color blindness in men is very high, about 79%. Actually, this is written in the book, I don't say this. Women only have about 8 to 9% of color blindness. And now imagine you've done 20 patients in a day, this is the last patient you're treating in the night. How many of you can see brown and yellow? Tell me please, very genuinely. So now what do you want to believe? Infected or affected? Affected. Leave it. Secondly, someone said soft dentine. We have to scoop it out, right? But what do we remove caries? Spoon excavators? When did you sharpen your spoon excavator last time? 10 days? 20 days? 20 years? 200 years? Please tell me that. And now we are telling that with that ice cream scoop, we can remove caries. Neither can we see, nor can we feel. And then we promise a patient, kuch ho to wapas aana. Because we know wo wapas aayega. That's why we make such bold promises. The best way, what you're saying is not wrong, but add another way of doing it, which is known as caries dyes. They are not expensive, they are not elaborate, you need 30 seconds. 10 seconds to apply, 10 seconds to wash, and 10 seconds to wash. So apply, wait, wash, 30 seconds. Now whatever you see as colored areas are the areas which are infected, means they cannot remineralize back now, no matter what you do. Whatever doesn't stain is the area which is remineralizable. So you leave what is not stained, but what is stained has to be removed. So a lot of people ask me, what if this exposes the pulp? Let it expose the pulp if it has to. All exposed pulps do not go under root canal treatment. If it's a clean vital exposure, you can do pulp capping. If it's a little bigger exposure, vital pulp therapy with biodentine or MTA, and you can still save the vitality of the tooth. But the rule is start peripherally. Always start cleaning on the periphery. Your last touch should be at the pulpal head. So that even if it is exposed, it's a neat and clean exposure. Because there is an alternate philosophy these days. Leave caries behind. Remove everything but leave at the head of the pulp. Now this is something is difficult to digest because caries has bacteria and we cannot bury and expect the bacteria to die. You can make it inactive for probably a couple of months, maybe years, but they will regain activity. And that's why a lot of restorations we do, tooth becomes non-vital without even troubling the patient. Why did it become non-vital? Did we cast a spell on the tooth? It was the bacteria which was sitting inside which slowly caused non-vitality. So please, when you see histological pictures like these, all the stained portions of dentine are the weak, unbondable or non-bondable portions till you reach the darkest or the transparent zone of dentine. But again, when I discuss bonding, I'll tell you, even this is a challenge. If you don't have transparent dentine, bonding is a big issue because it's hypermineralized. Then comes one of the most glorified aspects of our day-to-day dentistry, known as pulp protection. So how do we protect the pulp? Give a 3 mm layer of glass ionomer on top of it. That's not pulp protection. We're just sealing the pulp from something. Again, going back to what we saw, should your pulp protecting agents be elastic or very hard? Because you're putting them on dentine. So you want flexible ones or rigid ones? What is glass ionomer, flexible or rigid? So people come with RMGIC. It's again a resin modified glass ionomer. Still the glass is there and you cannot bond to it. So you have to etch, you have to bond, but it's still a mechanical bond. It's never a bond which goes inside the tooth. We need at the pulpal layer something which is not rigid, something which is elastic. Elastic like a thread so that even if there's any shrinkage happening, it can expand and contract, come back. And those things are only possible not with calcium hydroxide, not with forms of glass ionomer. They're possible only with calcium silicates which have resin in it. So no more calcium hydroxide as liner or a base. Shift to resin modified calcium silicates because these are the ones which protect the pulp because they're bioactive. They have the flexibility of dentine. And the best part is you can etch and bond off top of them. They're absolutely bondable. And how do you trust that this is a good material? Any material that you want to buy, please do not listen to anyone. Because in the morning we had the discussion in Principal Sir's office. Companies come, they talk about the products, they go. No one helps us in research. How would you know whether you would want to use a material on your patient if you don't have research? Best is research. What is the second best thing? Reviews. But reviews from whom? Not from Facebook, not from YouTube. Reviews from research agencies. There are 3 research agencies and as students you guys should be reading those every day. One is known as CRA newsletter. The second one is a book called Dental Advisor. And third one is a book called Reality. And they're all available online at very nominal costs. Every 2 years, 3 years they give reviewing of materials. And materials which get 5-star ratings are the ones which are the best. That's how I pick and choose my materials. Once you have done everything, have we killed bacteria? Can we see dead bacteria? Are you sure that your white looking dentine is bacteria free? Okay, one big glitch in this entire sequence is rubber dam isolation. How many of us use rubber dam for every case that we do? Maybe not. And imagine you've done 1.5 hours of hard work and you're just about to push the last dot of your material and the patient decides to bus. That's it. Just about a couple of million bacteria back into your field. And now what do? Ideally and ethically you should go back to your first step. But we just restore. God will take care of us. See? Okay. Yesterday we had a very funny incident. It was the 5-second rule. So we were taught as kids, if something falls on the ground that you're eating, if you lift before 5 seconds, it's not dirty. So if the patient is 5 seconds less than that, it's okay. 5-second mommy's rule. But if not, please either repeat, Before you have to do all that problem, isolate. Use rubber dam. Even under rubber dam, bacteria has been deactivated, we do not know. So before restoring, before etching and bonding, if you're doing a total etch technique, there is a bonding agent available. It has an active ingredient called the benzalkonium chloride, which is antibacterial. So if you're doing a total etch technique, if you etch with this, you've achieved a lot of bacterial sanitization. But if you're in a deep cavity where you do not want to etch, then there is no substitute but for one material called chlorhexidine digluconate. Take it on a clean bonding brush, scrub your dentine gently for 10 to 15 seconds, wait for 10 seconds and wash it off. What does this do? Chlorhexidine by nature is antibacterial, antifungal, antiviral, everything that you can think, it's anti that. But the best part this chlorhexidine inhibits is matrix megaloproteins. I mean, whoever is doing restorative dentistry with passion, you would know, bonding is troubled only by this substrate called MMPs. They live in your dentine, they come up, they degrade your bond, and 2, 3, 4, 5 years restoration is out. But if you have used chlorhexidine as a cleanser, it gets absorbed on your hydroxyapatite and stays there for a long time, negates all your MMPs. So you could use either of the two. But when I said you have to etch the tooth, we have two words, total etch and self etch. Is this called total etch? Flood the tooth in for 30 seconds. Enamel and dentine have to be etched separately. Enamel can be etched for 30 seconds. Dentine, vital or non-vital, cannot be. Because you still have the collagen which will dehydrate and collapse. So if you say 30-second etch, you first etch the enamel only for 20 seconds. For that you have to have a very good thick viscous gel etchant which doesn't flow. So you just put the etchant on the enamel first, 20 in your mind or a clock watch or a stopwatch, 10 onto your dentine. So if you see dentine gets how many seconds? 10. Enamel gets how much? 10 plus 20. So you've etched enamel for 30, dentine for only 10. This is known as a selective etch pattern or a preferential etch pattern. But now with the newer generations, the 8th generation, which say do not etch. When you say do not etch, what do you call these bonding agents as? Enamel bonding or dentine bonding? They were traditionally called as dentine bonding agents. Because enamel everything bonds to. So when they say do not etch, they are meaning dentine do not etch. You can still etch enamel. In fact, you have to etch the enamel for 10 seconds. Because whatever you're cutting with your burrs, your dry metal, etc., they're creating dust, and that dust has packed the entire of enamel surface. And now I put a self-etch adhesive, which is not cleaning it. So please etch the enamel only for 10 seconds, then use your 8th generation bonds. Once that is done, we get to the step of bonding. In between the two, there's one step which we say washing and drying. Please be very careful. How many of you have tasted the acid etchant? It's very tasty, na? Did you want to repeat that again? Oh, it was so nice. Why did you not? So every time after lunch, dinner, take a drop, enjoy the taste. No. Then what happens to those poor patients when we are washing and it's flooding, it's in the throat, going into the stomach, everywhere? See, patient is also a human being and they have taste senses. Acid etchant is one of the worst things. And if you want to know something worse than that, it's not sodium hypochlorite. It is normal saline. Taste it and you will know how disgusting it is. And everything is flooding in the patient's mouth. So if you're not holding a rubber dam, at least hold a high wax suction on the tooth. Wash it slowly and gently. Now you have to dry the tooth. How do we dry the tooth? I can read lips. No one is saying loud, but I can read lips. 3-way syringe. 3-way syringe is again the most destructive thing for collagen. The pressure is so hard, your collagen will collapse. It's like you go and wet your hair to do shampoo, but then you use a dryer on your hair first. And now you put the shampoo. Will the shampoo work on your head? It's the same thing. First we make the collagen clean, then you put a blast of air, which is the dryer, all the collagen collapses. Now we put the bonding agent. How will the bonding agent penetrate? It has to penetrate through the collagen. So please use a very expensive instrument called the chip blower. Very, very expensive. Please buy it, keep in the lockers or your bank FDs. Take it out when you have to use it, blow air and save it again. Do not use 3-way syringes. Now comes the bonding agent. So we apply the bond. Right? So how do we apply the bond and how long do we apply the bond? Is there any designated time? If yes, then who tells this to you? So how many of you apply for 20 seconds? Some maybe for 30, some for 10. The decision is not mine and yours, the decision is manufacturer's. So the time, the curing time and the application time, application steps, everything manufacturer tells you, listen to them. They also say a certain thing which is the mode of application. So I'm going to use 3 words, please tell me which one sounds logical to you. Should you apply the bond? Should you scrub the bond or should you agitate the bond? All bonds we will scrub. When I'm asking you something, see, by now at least the people who know me, they know it. If I'm asking a question, it has to be something wrong. It cannot be simple. So please now, for future questions, this is your hint. If I'm asking very sweetly and politely, something is wrong. Now when I say apply, when you apply the bond, what are you trying to achieve? There is some monomer, some primer, some adhesive, right? Some solvents, which we are trying to push the adhesive into the dentine and they should evaporate. So now let's talk about a bond which is very acidic. We apply just gently, we leave it, it's going to demineralize on its own. But now by mistake, if you scrub it or if you agitate it, what's going to happen? It's going to go deeper, create sensitivity. Second scenario, a bond which is mildly acidic and we just apply and leave. It won't penetrate. 3, a bond which is based on water philosophy, which cannot demineralize, which you have to agitate. You scrub or you apply. Either of these things won't work. So please see what your manufacturer tells you. They are telling this application mode because of chemistry, not because of how I like to hold the brush. Then coming to choice of bonds. Now it's just you could say symbolic that I'm putting a few pictures. You can choose whichever one you want. There are certain things that you should know how to select a bond. Number 1 and the first and the most important is bond thickness. When we apply the bond on the floor, it should be very, very thin, as little microns as possible. So please read the literature. Like this bond says it's about 20 microns to 25 microns. This gentleman claims I'm 10 microns. So if I have to choose a bond, I have to choose the thinnest bond possible. Second, for deep cavities, color doesn't matter. But for translucent dentistry, let's say you're bonding Emax veneers or hybrid veneers, your bond should be as colorless as possible. Third, something which is known as, I'll come to that later. Okay, this is what I was talking about, technique guide. All manufacturers publish literature in 7 languages. Even if you don't know either of those 7 languages, no problem. At least you can see pictures, they tell you pictures. Storage, refrigerator. 10 minutes before use, take it out. Dispense not on your brushes. Mix it nicely, dispense in a clean covered dish. Application time, 15 seconds 1, 15 seconds 2, do not cure, wait for 30 seconds. Everything is in a picture. Air dry for 5 to 7, 10 seconds. Light cure, 10 seconds. Everything is mentioned. And every bond, every adhesive will have a different manufacturer's recommendations. But just one thing, when they say this 10 seconds, please remember your light curing has to be very good. I'm talking about the intensity. Whenever using the 8th generation bonding agents, just one thing that you know remember is, do not start from dentine first. First, rub the enamel gently because it needs more demineralization time, then go to your deeper dentine. So whatever time is there, always start from enamel first. Now when you're doing this so-called philosophy of bonding, what are we achieving? The resin tag has to go into the dentinal tubule like these small extensions. So it's like these extensions, and when you cure it, when it's trying to pull back, these extensions are holding it back. So they are like your claws which hold the wall. Now let's talk about how it happens. You apply the bond, you cure the bond, these small tissue, the resin tags that are there, they've gone inside. And we all know resin will shrink. I'm not saying it doesn't shrink, it will shrink. But if there is one surface pulling it forward and 25 pulling it backward, where will it shrink? No points for guessing. It's going to shrink towards the tooth. Why did I say thinnest film thickness? Now, as much of thickness on top of the surface is going to be pulled outwards. As much of thickness which is lesser on the tooth surface is going to be pulled backwards. Now everything is going right, and we have been introduced to a new material in our market called bulk fill. Bulk fill means one shot pack, one shot fill, one shot destroy, not restore. We cure it, there's a bulk fill material. Now this was a very thin film, microns. This is millimeters. So now when they start to pull each other, please guess and tell me who can win the race. The thin 12 mm micron tissue tag, resin tag, 10 mm micron thickness, or 4 millimeter deep cavity. And this is what we do every day. Now once you've done this, what happens? Whenever the adhesive layer gets pulled up, there is an air pocket, air gap. The patient will bite on it. What will happen to this air pocket? You're bursting these blisters every time. And when you burst this blister, the energy goes into the dentine. How will the dentine react to it? Very simple. We all know this philosophy, fluid dynamics, movement of fluid up and down, hydrodynamic theory. Patient starts getting pain and sensitivity. And when these moist levels come to your surface, they break your bond. It is known as hydrolytic degradation. And this concept was given by Peter Tay in the year 1996. If someone feels bad, a lot of people in this room were maybe not born, or even if you were born, you were this big. That time also researchers told moisture is bad. So please try and control it. But we were not doing it then, we are not doing it now. Because what are we looking at? We're looking at shrinkage, right? Shrinkage at every level. What is shrinkage? Shrinkage is nothing but monomers coming together forming a polymer. So these are 5 monomers. They come together slowly, they form a polymer. Did individual monomer miss its volume? Which volume did we lose? Intermonomer space. So when you cure it, they condense together. Now, first aspect, there's a lot of material in the market available which says you can cure in 1 second, 2 seconds, 3 seconds, etc. Shrinkage has a bigger problem. It is not just the shrinkage, it is the shrinkage stress. So now, look at these fingers and tell me, one way I'm shrinking it slowly, 20 seconds. In second place, I have shrunk in 2 seconds. Which of the two has given more stress? But we all believe in a 3-second cure. This is how we get fooled every day. So the problem is not shrinkage, the problem is the stress by which it shrinks. See, something which shrinks very slowly, you leave it, it will recoil. If you shrink it very fast, it will recoil fast. So fast up and down, again dentine is showing movement. So what are the problems this stress causes? You can see so many of them. But let me give you a very simple example. You have a pair of a sweater or a shirt or whatever. One is of cotton, one is of an elastic material. And now imagine both of them have shrunk, equal amount. And you have to get back into both of them. Which is easier? The rigid cotton or the elastic one? Though both have shrunk, but still the elastic gives you the capacity to put something inside by expanding it. And that is the philosophy of enamel and dentine composites. Dentine composites by nature are flexible. So even if they shrink inwards, they will not shrink too much. And when you give it time, they slowly relax back. What does enamel do? It shrinks and it stays like this. So now when there is stress, what will happen? It will give up. So when you have a tooth, you applied the bonding agent on top, you apply a layer of an elastic. This elastic could be a glass fiber or any kind of a fiber which is making sure that the bond and this fiber becomes one body. And once this is cured, now you cover it with a composite. When we start curing our composites, now what happens? There will be shrinkage. So one vector will pull it down. The bond and the fiber is pulling it down, but composite is pulling it up. This will keep on happening. But what will be the resultant? Nothing, no shrinkage. Or if it is there, least amount of shrinkage, but no stress. Because whenever we cure materials without any elastic layer, the stress directly goes to the deeper layers. But whenever you have an elastic layer in between, please again go back to your reception and see. This is the net which is tied. So whenever there is force, how will that net behave? Down? Will it stay there? Back up. That's exactly what you want at the pulpal surface. Stresses to hit, absorb and back. If it's a hard material, how will they behave? They will hit and continue. This is just a very thin glass. It's a micron sized glass. You just have to make sure on the adhesive layer, the bonded layer, you put one drop of a very thin flow, a dentine flowable, and put this sheet. Now this is going to act like the elastic which is pulling everything down rather than pushing it up. So when we do the demonstration, I'll show you exactly how this is done. Now the couple of fibers in the market available, we're not going to take names and say who is good, who is bad. Please use your wisdom when you choose any material. Number one, the fiber that you're supposed to use, it should ideally have some kind of a bonding agent in it so that it can stick to your adhesive layer. Which is better, if I apply it externally or if the manufacturer applies it industrially and gives it to me? Which is more predictable? When it's applied by the manufacturer or when we are applying and leaving air pockets behind? Obviously the one which the manufacturer has done. Then coming to the strength. The two kinds of strengths that we are talking today. One is compression, fracture toughness. Second is flexion, means flexibility. And where am I asking you to put this fiber? Right at the base of dentine. Is that area fracture tough or flexible? What is dentine? Flexible or hard? So you need something which is flexible. So please check flexibility. And please, I would always say, do not trust what I am telling you today. Go ahead and read the articles of research. At dentine, you do not need anything which is fracture tough, but you need something which is resilient. Now what happens when we have these huge cavities, you have stress on the tooth, the stress goes down and it starts breaking the tooth. And where does it break most commonly? Does it break at the cuspal surface or at the cervical margin? That's why we lose teeth. Because the areas of stress concentration are much deeper down, not higher up. Now this is how a tooth behaves when you have cut it. You have force coming which is causing compression. You have force coming which is causing tension. Tell me which is easier to break. And that's why functional cusps under load give up. That's the reason they give up, because it's not the compression, it is the flexion which is breaking them. This is an FEM analysis, a finite element model of an intact tooth. So when loads were given on this tooth, please look at the pattern of stress. Was the stress at one point or was it through the DEJ up to down? And remember, what is this shape? So do you want flat cavities or do you want saucerized cavities? For composites, please do not make flat floors. Make your cavities with round diamonds or round carbides like a saucer, so that the stresses do not get concentrated, they get distributed, and that's the pattern of distribution. Pattern of distribution is never flat. It's always slightly round. Then coming to those deep class 2s or those designed class 2s. Which is the part which fractures the first? Proximal box. Why? Because we have left a sharp splinter inside, which is, and if that doesn't break, the stresses start going to the lower portions of the tooth. So no saucerized cavities. Even if you have a class 2, there should not be a defined fall or defined flat floor. Please, as round as you can keep it without giving it geometry. Because if we give the sharp edges, all risks will still agree. You'll have stress concentration, you'll have debonding, you'll have cracks, you have fractures, sensitivity, everything can happen. And the sequel to this is very simple. When it has to go wrong, it will go wrong. And now when this happens, if it's a lucky supragingival fracture, root canal post-core crown, if it's an unlucky subcrestal fracture, extract, and you all know the story. I don't have to teach you that. But if we have tried to reinforce it, as in you have used softer materials now, you have used a dentine based composite, you've used elastic fibers, you've used fiber sheets to cover everything, you've tried to make onlays and overlays only with let's say Emax, but the entire core is restored with soft dentine, the life of this restoration becomes quite long. You can use these philosophies like fibers to reinforce everything. Now, if I want to glorify myself and say how much I know, I can tell you I am doing decoupling, I am doing tenting, I am doing wallpapering, fiber basket. Please give me a break. All I am doing is taking my fiber, if I place it on the floor to decouple from the adhesive layer, it's called decoupling. If I place it 360 degrees, wallpapering. If I place it like a tent, tenting. These are all different names given. If I do a full fiber basket, fiber basket. All I am doing is checking which part of my tooth is weak and taking a fiber and applying there. That's it. So choose the area which is weak. You can reinforce them. For anteriors, for posteriors, both. The best is when you have small crack teeth. Now, whenever you see a very minor crack, I'm not saying frank cracks which are splitting the tooth. Those minor small cracks on the tooth with your magnification, are you supposed to drill all the through the crack, or you can just leave the last couple of microns of that crack? So let me give you a real day example. When you drive a car, you must have seen sometimes when you're driving a small pebble or a stone from the road hits your windshield and you have a very small crack. What happens the next day? Slightly bigger. Fourth day, even bigger. 10th day, even bigger. After 2 weeks, through and through. But the good quality is because it had elasticity in it, did it break and shatter? But imagine when you had that small crack, you put a small sticker. 3M gives you those repair stickers, right? You put that small sticker on the crack. The crack never propagates. Have you ever thought why? Because now that crack was contained under an elastic layer. If you have minor cracks, you can put these fibers on top of them. The fiber is going to take the load. The crack will never take the load. So again, saving teeth for the longer time is more viable. Which is the areas of stress concentration? The base. So if you can add the fiber at the base like a U, your entire concentration of loads has been taken care of. And if you want to do big restorations, bulky restorations, one fiber at the base, lot of dentine composite in the center, create a DJ again with the fiber. And this is exactly what I was seeing when I entered the building. Exact same shape. And now coming to the material, which one do we use? So this is something that we use every day, right? Bulk fills, big restorations. When you see this, look at the tooth first. Which part of these two, first of all, tooth was never monolithic. So you cannot have one substrate. And secondly, which is bulk in these two? Is this called bulk or is this called bulk? Which is the bulkier portion of the tooth, enamel or dentine? So don't you think even God is giving you a hint? That if you want to do a bulk fill, which substrate can you bulk fill? Enamel or dentine? Only dentine, because dentine is elastic. Enamel cannot be elastic, and whatever is not elastic cannot be bulk filled. So if you do this, one restoration, one substrate, it's not natural. There are a lot of techniques which have been taught, but this is not what we want. Even if you want to do a bulk fill the dentine and then layer the enamel. Never bulk fill enamel. So this is wrong. Creating a segregation of enamel and dentine is right, and that's how we restore teeth. Another problem of bulk curing is you cure it from the top. Where would you think the material is going to shrink now? Because see, composites will shrink. You cannot stop the shrinkage. One of the walls will give up, definitely. And which is the most prominent wall? The wall which is farthest away from the light. Which sadly is your pulpal wall or the pulpal floor. And this is closest to your nerve and the external surroundings. So either there is leakage or there is sensitivity. Just to avoid to understand that it's not the shrinkage, it was the stress it was imposing. So if you were doing small increments, the stress was as less as possible. Or if you were using flexible material, the stress was as less as possible. This picture is from the year 1991, given by an excellent researcher, Dr. Diagnostic. He is based in Switzerland in the University of Geneva. If you research his name, you will at least find enough literature for this life. I'm not talking about the afterlife. This life you'll be sorted reading. He told in 1991 that the base layer should always be a low viscosity, low shrinking, flowable composite. He never said universal. On top of that, you could use a body or a flexible dentine material, and the enamel should be just at the cuspal region. That's it, nothing beyond that. And that was 1991, this is 2025. Philosophies have still not changed, they're still the same. So okay, these are all very good materials. I'm not taking away the beauty, the polishability, the fracture toughness of these materials. But can I use them as enamel or can I use them as dentine? Because honestly, you cannot use them as both. There's nothing called enamel dentine composite. Universal could either be enamel or be dentine. So what is this? When it's highly polishable, fracture tough, what rings a bell? Enamel or dentine? And where are we using them? As flowable layers bang on dentine. That means I was saying that this layer should be flexible at the pulpal surface. What mistake did we do? Made it hard. So now when it's hard, if there is a crack, will the dentine remove the crack or will it propagate the crack? For dentine replacement, you have to find dentine composites, and trust me, all companies make it. The problem is we don't ask for it, so they don't give it. For example, Dentsply has something called smart dentine replacement. Ivoclar has something called IvoFlow, and they're all dentine composites. So where do we use them? Where we have small defects, where the propagation of crack is not very deep, where I'm not 8 mm, 9 mm into the dentine, I can use these as my dentine replacement. These materials, they have some cushioned modulators in them, like elastics. So have you seen the orthodontists when they work, they tie elastics to two bands? It tries and pull and push, right? But what happens after 30 days? Why do they need to change the elastic? Because the elastic modulus has finished. That's exactly how they work. When you cure, they get stretched, like the elastic on an orthodontic bracket. But when you leave it for 30 days, what happens? Relaxes, pressure is gone, no more pulpal stress. But then gets me to think to another point, that these materials are just monoblock composites. They do not have any fiber or fibrous interstructure. What does dentine have? Does dentine have collagen in it? Type 1 and type 2. And this is the structure of collagen. So if you notice, collagen is coming straight, collagen is coming obliquely, it's intertwined. It's just basically spread all over the dentine. So if I am in a deep cavity and if I have a material which gives me fibers also within my resin matrix, it's a better bet for me. And that's what gives me the luxury that I have to use is materials like these which have fiber entwined in them. So the two kinds of fiber based composites. One is you have chopped fibers which are mixed into your resin network like this. So you either have a flowable or a soft body composite. Your fibers in random orientation. Or you have dentine material which has fiber-like sheets in it. Both of them will work the same. Both of them will do the same job. Because if I do not have a soft fibrous base here in my core, what is going to happen? Loads will come on my tooth. It's all universal, hard composite. The hard composite will concentrate my loads, and sooner or later, something will go off. But if I have filled this tooth or restored this tooth with something which has fibers in it, fibers means like a sheet of elastic. Start applying load on this tooth and see what happens. What is going to bear the load first? The tooth or the elastic? See, it was raining outside when we were coming. Did we stop the rain? No. Did we fly? We all walked. That means water was still there. How did we prevent from getting wet? We took an umbrella. So what stopped the raindrop from hitting my body? Umbrella. This is your umbrella. It stops the force from hitting the furcation. It is not removing the force. It is not doing anything else. But this elastic layer, which has a sheet intertwined, the moment there is force on it, it acts like your first layer of protection. To break this, the patient will have to be bruxing for the next 10 years. So restoration which is chipping off every 2 months, 3 months, forget couple of years, it's not going to break and chip off. So you could use these philosophies when you're restoring teeth. This product is known as a cube. Cube means because the structure is like a square cube. It has one layer of dentine composite on top, one underneath, and a mesh of glass in between. So when you pack it, if you want to have horizontal packing, you will horizontally pack it. If you have a weak cusp, you can obliquely pack it. So the fiber will take the shape of the load bearing area. So once you've applied your adhesive, you've applied your fiber sheet at the pulpal area, all you need to do is one cube after the other, wherever you need them, light cure it, second shot. It's again not a bulk. The cube may be looking like a bulk, but you do it incrementally. One cube cure, second, third, as many you need. And finally the enamel on top. Now once we've done that, now when the force falls on this tooth, everything is same. As I said, the rain did not stop, we did not remove the water, but we held an umbrella. And all the forces are going to be counteracted by this particular fiber, and the tooth is not going to break. So the deeper your cavity, the more stress on the outer side. And see, imagine just a central class 1 cavity and a cusp fractures. It's not because of the extent, it's because of the depth. So the deeper you go, the more careful you have to be in terms of replacement. So we do the fiber first. Now you put either of the fiber based materials in increments, not in huge bulk. And now whatever enamel layer you have to put, please put it. This is not technical. Any universal, any enamel will work. Because the fact that makes the tooth strong is not how hard your enamel is how much stress the enamel can put on to the DEJ, and how the DEJ distributes it to your dentine and periodontium. So for that, we need to understand the role of elastic materials in between the force of the enamel and the base of the tooth. So in between the two, whatever and how much ever flexible materials you have, the longer your tooth is going to last. And as I said, on top, put anything that you have. Everything works. So you don't have to worry about which enamel composite is good. Now, all this is materials that you see are light curable composites, right? None of them are dual cure. So let me just touch upon a very simple aspect which is called light curing. Does every light cure? Okay, which is a good light? Tell me, which one is a good light amongst these? It could be all of them, it could be none of them, it could be some of them. So like I asked you about your spoon excavators, that when did you last sharpen them? Now second question is coming, when did you last check the intensity of your curing light? 3 weeks? 3 months? 3 years? Or probably granddad gave it to dad, dad gave it to me, I'll give it to my son, it's still shining. Do you ever realize these lights, they have a life? And if you do not keep on just servicing these bulbs, they will fuse. See, this is such a bright light which is shining. They will just always shine like this. 2 years, 3 years, the light will dim off, 5 years it will fuse. Exactly the same thing will happen here. So if you don't keep on checking the intensity or getting it serviced, it's going to fuse. Please look at the parameters you should see before you select a light. And remember these, curing tips have to be big, 8 to 10 mm, so that you can cure long or big areas. Distance of the tip of the light from the composite should be how much? 1 millimeter. If you're curing from 2 feet away, it's not curing. Have you ever seen your light curing, the light tips that you have, they come with an orange cover, like a cap. How many if you still have it on your light? Or it's playing somewhere else? It has been designed very scientifically according to the tip size, so that when you put it onto the tooth, light doesn't scatter, and the distance of light in composite is 1 mm. That gets me to the point of beam spreading. If your beam is spreading while you're curing, it cannot cure. It has to be concentrated. So be as close as possible. Very important is exposure time. This is directly related to the intensity. If your intensity is 800 milliwatt per centimeter square plus, only then manufacturer's recommendations work. What if it's 600, 500? You cannot cure from the same time. You have to keep on increasing the time. But the more time you increase, more chances of pulpal damage increase. So try and have good intensity and cure lesser. The shape of the light. If your lights have an angulated tip, it gets very difficult to go to the posterior areas. See, if you have a flatter tip, it's very easy to cure. Light will go through and through. But if your tip is angulated and your area is not accessible, now when you cure, what is happening? It's not touching certain parts. You overcure, you cure for 20 seconds, 40 seconds, 60 seconds, it's still doing the same. So when you plot a graph, you see this, that this has been cured, the uncured areas are still soft. And that causes leaching of monomers, that causes sensitivity, that causes debonding, it could cause anything. And whenever the restoration falls, whom do we blame? My restoration failed. No, I failed my restoration. Please rephrase this statement. Lights should be as flat as you can get them. And then comes from where to cure. Dentine, please remember, is elastic. Even if you cure from the top, even if it shrinks inwards, it will recoil back. But can enamel do the same? And I started with the statement, sensitivity is good if you know how to make it shrink. When you're curing your enamel margins, please do not cure from the top, because when you cure from the top, where will it shrink? Away from the margin. Start doing trans enamel cure for each cusp, one by one. So when I cure the mesiobuccal cusp, mesiobuccally, where will my composite shrink towards? Inwards? Was I wrong when I said I'm utilizing it for my benefit? I'm making my margin and my composite tighter by making the resin shrink towards it. You have a perfect seal. But now imagine you've touched two walls, buccal and lingual. You cannot cure from both the sides. You cure from either of them, it will get pulled up. So please, one cusp at a time. Never cure from the center as a bulk. Always trans enamel. And finally, finishing and polishing. The most important question is not which is a good tool. A bigger question than there is, when do you start finishing and polishing? Because what we do is, the moment our restoration is done, we start rubbing it. So let me just point out a concept which is published in a textbook, which says the moment you cure the composite, in a shrinkage, it's under a state of high compression. Means it's right now very tight. If I take a balloon and put a pin on that and a tight balloon, what will happen? It will burst. That's exactly what happens here. This bursts. The margins open up. We have white line defect, we have leakage, we have bacterial contamination. If you just leave it for 10 to 15 minutes, what happens again? That initial shrinkage relaxes. It gets back. And now when you try and burst the balloon, it doesn't burst. So the balloon from the previous night to the next morning, you will have difficulty bursting it. Why? Because it has recoiled. Please give it at least 10 to 15 minutes to recoil. Once that is done, you can start doing your occlusal adjustment, initial finishing, etc. But when do you give that final beautiful polish, that glaze to your patients? It cannot be done immediately, because composites never cure 100% on the same day. Maximum rate of conversion of monomer to polymer is about 70 to 80%. The rest 20% is still an ongoing reaction, which takes 24 to 48 hours. Now what if I polish immediately? It starts shining. 2 days later, what happens to the restoration? It's dull. Because this was not the shine that I wanted. When I was rubbing it, the uncured monomer, which is heat sensitive, traveled up like thermometer mercury, came on your surface, gave you an artificial shine. Patient ate, chewed, brushed with it, monomer washed off. Defects inside, surface rough outside. You wait for 24 hours, minimum. If you've done too much of characterization on anteriors, like added tint, stains, etc., wait for 48 hours. Sometimes you've done a final polish after 7 days. Because this is the time monomer conversion to polymer and water sorption is happening. When water gets absorbed, it hydrates the matrix, and now the shine that you get is the actual shine. So try and do it not on the patient, just as a test. Take a sheet of composite, polish it as much as you can, drop it into water today. Take another sheet of composite, finish it today, don't polish it, drop it into water, take it out after 2 days, repolish it, and now compare both of them, 5 days, 10 days, 15 days, 20 days. You will realize which one is staining, which one is not. A big reason of composite staining is immediate polishing. And even before you start finishing and polishing, please use clear glycerine on your surfaces. Because composites, they bond by something known as oxygen inhibition. So one oxygen is inside, one is outside. That's how 2 layers bond. But the last layer doesn't have anything to bond to, so it's a weak link. So when you put clear glycerine on your surfaces, the oxygen within the glycerine becomes a part of your bonding mechanism and stabilizes the free radical on top. The technique is fairly simple. You start with adaptation first, and I always mention, the better you adapt your last layer, the lesser you'll have to finish and polish. Please, with composites, do not cut and make shapes. It's not amalgam. You have to sculpt your composite. So use fine instruments, brushes, pads, so that you create nice soft anatomy. Once you have cured and the patient is ready for finishing and polishing, first step, gross reduction, like occlusal adjustment, your margin placements, your coarse finishing, which is done with either yellow diamonds or fluted carbides. Once you've achieved some of that shape, now you start giving a smooth surface. You cannot use diamonds here, no matter how fine your diamond is, because diamond is scratchy. If you're using a 64 fluted carbide, please use it. If you're not using it, use polymer cups and cones, which come with different polishing systems to make the surface smooth. At this point, after 15 minutes, you can send the patient back. Call the patient 24 to 48 hours, final polish, either wet or dry, both options are there. Wet means pastes, dry means cups, cones, spirals. And the last step which I am showing, please be very cautious. It's only for posteriors and margins. It's not for buccal surface of anteriors. Something called glazing. Now glazing is not putting a bonding agent on the tooth. They are clear resins. They do not have any adhesive in it. They do not have any fillers in it. You just are supposed to use it on the margins so that margins don't leak. So this is the first step of your finishing and polishing. Where you start finishing it, you will see there are a lot of different shapes available for the grooves, for the flatter surfaces, for the cuspal slopes, etc., for anteriors, posteriors. Then you have pastes. You can use pastes. Please remember, stick to whichever company you want and whatever material they give you. If I am doing finishing and polishing with something which is diamond based, I need thick nylon cups. If I am using something which is alumina, I have to have felt discs. So if I polish alumina with this, it's not going to give me any polish on the surface. Or you could use spirals. These are very popular these days. They say you can do it dry and wet both. But when they say dry wet, doesn't mean that you don't have any water on the tooth. Water is still necessary to reduce the temperature of friction. And second is to clear the dust off. And finally, once everything is done, before you send the patient off, one last layer is surface sealing. So how we do it is, we apply the etchant only on the margins. Please be careful. Don't do it on your polished surfaces. If it's an anterior veneer, expose the margin, veneer margins. If it's an onlay, onlay margin. If it's a direct restoration, cavo surface. Wash it off, apply your sealant, light cure it. Let me just go a slide back. What do these sealants do? These are the sealants which are available in India right now. In fact, there's only one commercially available. This gives you a good gloss. It protects your surface and makes it plaque resistant. Now imagine this patient is eating, chewing, biting. How long do you think the patient will take to break this laminated layer? If everything is fine, it takes about a year for this to chip off completely. And when do we advise recall to our patients? How many months? At least 6 months. So ask everyone, on a recall, what is the simplest thing you can do is polish your surface, etch your margins, laminate it. Let the patient go back, break it again. Again 6-8 months, what do you do? Will there be leakage ever in this tooth? Because when you're etching it, you're creating an area of demineralization. What penetrates into that is this resin. And now bacteria cannot penetrate through this resin and go into the tooth. And even if they have, I'm again using the antibacterial agent after 6 months. Again deactivating them, again sealing this layer. Start doing this and your restorations will last the longest. So just to show you a couple of clinical cases. Okay, how do you take this tooth as a diagnostic criteria? Is it simple or is it tough? Looks like a small cavity in the center of the tooth. Always remember, the smaller they look on top, remember how Titanic sank? Just a tip of the iceberg and the entire ship sank. Never trust these small fellows. They're the most naughty of all. Because when you start drilling them, see what has happened. We keep on using dyes, we keep on cleaning them, we keep on using dyes. This is a huge surface defect. And imagine that small dot and this hole. But now the surface is clean. Dyes have given me a very clean surface. I can etch and bond. But what is my challenge now? You see this dark demineralized dentine? This is very close to the pulp. If I put an etchant here, the chances of pulpal sensitivity is going to be high. But if I don't etch it, I cannot bond to this. So what do? I'm in a catch-22 now. If I etch, I am dead. If I don't etch, I don't bond. Because self-etch adhesives do not have enough acidic potential to go through them. There's the third option. Alter the surface. How do I alter the surface? I disinfect with chlorhexidine. I wash it nicely. Remember the pulp protecting agent? Resin-based calcium silicate. I put that as a liner, not as a thick base, as a very thin liner. This is a bioactive material. It has ionic bonding. I can etch and bond on top of it. So the non-bondable surface has been transformed to bondable surface. I'm going to use a universal adhesive, so I'm only etching my enamel periphery. That was the material that I put there. Once that is done, you remember the fiber I showed you, thin glass sheet? With 1 drop of flowable after the bonding agent has been cured. Can you see the fiber here? The net-like thing? You light cure it. Slight amount of flowable so that the fiber is absolutely covered, using very small thin layers. The thinner the layer, the lesser the stress. Shrinkage will still be there, stress will be very little. Once my pulp is absolutely protected from all the stresses, I can now bulk fill, but bulk not in vertically. I will put 1 cube for one cusp, second for the other. My dentine has been recreated. How much from the bottom topwards should you fill dentine? Or other way, how much of enamel clearance do we need? 1 mm, 2 mm, 3 mm, 4 mm, how much? Ideally 2 to 3 millimeters. Because in a vital intact tooth is 1.5 to 2. And now because we are doing something which is to replace it, just as an excess, keep it 2.5 to 3. But how will you calculate whether you have reached the last 3 mm? When I do the demo, I'll show you the instruments which are designed for this job. So no mental mathematics. You put it, it gives you a gauge, like your graduated probe from periodontics, something like that. Remember once we were talking about the design, we said fiber underneath, fiber on top, and everything is sealed. I have reached till the last 2 to 3 mm. Now I have to have my DEJ. I use the same fiber that you saw at the base, layer it through and through. So now the last 3 mm that I have will be enamel. I have one fiber on top, lots of fibrous dentine on the center, another fiber in the base. It's like a cage. Now whenever there is force on it, how many fibers does the force have to break to reach the pulp? It's like millions. And that's why the restorations will last long. You just do cusp by cusp. That's the last layer of oxygen inhibition. Finished, polished. And now the picture that you see is a recall picture 1 year later. And if I have to lie to my audience, I can very well say, see how beautifully I polished, it's still shining. But this is a big lie. It cannot shine because under occlusion, all shine is vanished. But what I do every 6 months, 1 year, I'll get the patient back, remember? Polish it, etch the periphery, apply the sealant, send them back. As many times they will come, I'll do the same thing. So all my recalls look very shiny. Not because I'm a very good polisher, because I polish and I glaze. And I protect my surface, not to shine but to protect. The previous one was small but deep. Look at this. Shallow and wide. Now one question to everyone here is, please look at the kind of occlusal surface this tooth has. Looks relatively flat. So if you imagine the tooth opposing to it, will it have a lot of anatomy or will it also be flat? So whenever you're restoring, please consider occlusion. If the opposing tooth is flat, don't start creating beautiful anatomy. You'll get disheartened when you have to rub it off completely. Now when we excavate, it's not going deep into the pulp, maybe 3-4 mm, but it's huge. All surfaces involved. We go the same way. First disinfect the cavity, selective etching. Can you see my fiber now touching all the walls? Previous one was only touching a little part of the pulpal surface, so I can call it decoupling. This is touching through and through. This is known as tenting. You are creating like a tent from front to the back, buccal to the lingual. So that whenever the forces are, all internal walls are holding my fiber and it sags and it comes back. Just cover it with a little dentine and cusp by cusp enamel formation, put your oxygen inhibition, that's your finished restoration. See, recall, nice shine. So now you know the lie of life. Nothing shines forever, not even diamonds, they have to be polished. But if you polish them, they'll always shine. This is the truth. A class 2 fracture. No points for guessing. Why did it fracture at the margin? Poor marginal integrity, wrong choice of material, and I'm definitely sure the design would have been pathetic. One thing which you have to remember, occlusion is very important. Please do not restore and start fixing occlusion. Your occlusion evaluation has to be done pre-operatively. You have to see these points. If I do not mark them before I start my restoration, I will never know where my occlusion lies. So the golden rule is mark your occluding points. Either I completely leave it or I completely include it. I will never leave my cavo surface here. That the opposing tooth is hitting my margin. It will break it. So opposing tooth occlusion lies completely on the tooth or completely on the material, never at the margins. So we excavate everything, we use our caries dyes. Again, no points for guessing, compromised bonding surface. So we isolate it, that's a sectional matrice. We alter the bonding surface, selective etching has been done. We bond the tooth. You'll see a fiber at the base, it's covering the flat wall and going slightly at the base like an L, a gradual L, so that stresses are managed. The rule for every class 2 is known as a centripetal technique. Never start making core first and margin second. Face the margin first. Once your margin is fixed, the class 2 has become a class 1. I'm again using my modified bulk fill technique, the glass fiber based composite. Pack it nicely once it's 3 mm inside. Put another shot. Enamel development, oxygen inhibiting gel, that's your restoration. Finished polished. The margin is now placed correctly. Please remember this anatomy is very important. The occlusal embrasure. If you leave it flat against an embrasure, it will break. So both the margins have to converge to an embrasure. You have to learn how to make this design. Contact is perfect. Patient is happy. Another case. Now please guess why did it break at the isthmus region? Occlusal stresses. The buccal and the occlusal, the connection is not important. What is important is what forces are lying here. And this is too narrow, maybe the opposing cusp is breaking it. So how do we restore it? You check the cavity depth, size, everything, make your evaluations, do all the excavations that you need. Again, altered bonding surface after caries dyes, you've sealed with a rubber dam. Modify it with a resin, your resin modified calcium silicate. Selective etch only the enamel, not the dentine. Hybridize means bond the tooth. And now see what are we doing. The cube till now was being placed flat. Now what is the orientation? Vertical. What is the orientation of force on this tooth? Vertical. So how should I place my fiber? Flat or vertical? So how do I place it vertically? I choose this cube, I tap it here vertically and I just roll it over gently. So the fiber comes straight and rolls over my sharp margin. Simplest way of redistributing forces. Go ahead, decouple the dentinal layer with another layer of fiber. That's your enamel composites done. Oxygen inhibition, cure it. That's your finished restoration. Now see why it was breaking before? Look at the opposing cusp. So what is the best way of treating this is orthodontics. Always tell your patient the right option, that we will orthodontically straighten this tooth up. We don't have to worry about it. But 9 out of 10 patients do not accept this plan. Because for one restoration, they won't want both the arches bonded. So if you cannot give them the right thing, at least remove the wrong. And the wrong was, this cusp was hitting the margin here. So it was breaking. Now my occlusion is completely on the restorative material. And please try doing this. Take 2 to 3 millimeters of composite, cure it, put it on the ground and stand on it. I can challenge you, it will not break. Composites do not break under compression, but they break very tightly under flexion. We've removed the flexion by adding fibers. We've removed the compressive loads by adding bulk. Now give this tooth a long life. That's after 48 hours. That's the recall visit. Again, no points for guessing. Why is it shining? Because it's polished and glazed again. A full surface loss. The entire lingual surface is missing. This light is too bright so you cannot see, but the entire lingual surface is missing. Buccal is intact. This is a clear-cut case for an overlay, onlay, directly or indirectly. We go ahead, we do the same philosophy. We've used a peripheral rim of enamel to close the entire lingual wall. The fiber goes at the base. Seal it with some dentine like we've seen. Apply the cube in the cuspal areas where you have to reinforce. The second cube for the second cusp. So the philosophy that we just saw in that animation, what do these cubes do? They go in the inner cuspal areas and give you that elastic modulation. Once you have that modulation done, overlay it with enamel composite. This is a direct onlay. We have utilized the buccal surfaces of our cusps and an entire surface has been remade under composite. Now try and break this tooth. Try and break this tooth under compression. Impossible. And why will this now not break under flexion at the enamel which is left? Because internally we've packed tons of fibers. So whenever the buccal wall will try and flex outward, what will the fiber do? Pull it back inward. But imagine this with a universal hard composite. The buccal wants to go forward. What does the material do? Please go and break. Okay, does this look difficult or this one should be easy, right? Small grooves. Not even bigger grooves like the first one. You cannot control bacteria. It's shameless. That's your small buccal cavity. But when you drill it, this is what you get. But please look at the cavity design. Buccal and occlusal have been connected, but there's a rim of enamel separating the occlusal and the distal. Remember the cavities I showed you. The more joint structures you give, the more they will shrink. Give them a barrier in between. That's your clean cavity. You can easily see how we are etching. Our etching is going through and through here, but there's a rim of enamel in between, separating the two occlusion and proximal cavities. Same way, the cube goes onto the occlusal surface through the buccal box. After we've transformed class 2 to a class 1, a full cube goes straight inside to bear the occlusal loads. Cusp after cusp, oxygen inhibition, slight characterization, recall restoration. One after the other, we can keep on seeing as many cases as you want. All of them will have the same protocol. And the protocol is very simple. Start from the first thing, vision. Your eyes should show you, and what your eyes cannot show you, your tools should highlight. That is my challenges. It's not this amalgam which is my challenge. My challenge is this full surface crack. So how do I do it? I remove everything. I see a very faint crack here. I see some altered pulpal floor. Make the pulpal floor bondable. Use a thin fiber sheet to seal the crack. And then you can go ahead and restore with dentine and enamel. So the philosophies do not change at all. Check for recall, finish, polish, reglaze, send the patient back. And that's what makes your restorations last longer. Not how strong my material was, or how I can use a hammer and tong it and not break? It's by giving internal strength, and that comes from dentine replacements. One last case, look at this one now. My challenges are pretty nice. I have an old amalgam, some broken tooth, I have an old crown which the patient doesn't want me to touch, and this has a negative contact. It starts buccally, ends up lingually like an S. If I do any indirect restoration, can I create a similar contact like an S? I don't have a path of insertion and exit. I cannot do it. Best I can do is a flat contact and always have gaps on that. So we isolate it again. You can see we have transformed the bondable surface to a non-bondable surface now. One drop of a flow. Just remember, one drop of a flow. I'm using a dentine placed flowable. You put the drop, you take your fiber, attach it there. The moment you have a drop of flowable, the fiber will sink in it. Take a rounded instrument, tap it gently so that it adapts nicely. A little more of dentine flowable covering my fibers so that fibers do not get exposed. And finally, cusp by cusp enamel build up. It's a flat anatomy. Why? Because the opposing tooth is flat. But if you see how contact has been developed, negative and positive both in one shot. That's the flexibility direct restorations give us. What would you do with this case? Half tooth broken. Let me excavate and show this to you. Almost on the pulp, barely buccal cusp left, 60% of tooth anatomy is lost. This is where a lot of us get tempted to do what? Root canal, post-core, crown. And if this is your tooth, if I ask you, please try and save it. That's the truth of dentistry. All dentists want their tooth to be saved, but a similar defect on the patient is either a root canal or an implant. Let's see if you can save this or not. You isolate it nicely. Again, no points for guessing. The first step is pulpal surfaces to be made more bondable. The fiber protects the stress. Flowable covering that so-called dentinal area. I use an enamel to create my palatal margin. More of fiber-based dentine in the core. Enamel cusp on top. That's after finishing. Nice anatomy, nice structure, good contacts. That's finished and polished. So the scope of restorative dentistry is not little. What is little is we don't exploit that scope. So if you want your restorations, not fillings, and please no more masala. If you want the restorations to last long, the only way to do that is respect nature. And what does nature tell us? Replace enamel with enamel and dentine with dentine. It's so simple. So whenever someone is coming in selling you convenience, that I can give you one material which will fill everything, what does that person think you of? Do they think you as a very scientific person or someone who's lazy? So if someone is selling you a lot of convenience and not science, please realize they are not respecting you. They are disrespecting you. And such people should not belong in your life. So please choose materials very wisely and restore teeth, not fill teeth. That's the entire, probably, the gist of today's discussion that I had. Is there any question that you wish to ask? Because after this, I'm just going to conclude the session. Any questions, any doubts that you have? Because this is a huge presentation. I can go on and on. So if you don't have a doubt, let me clear my contentions and give you my submission. For me, in my practice, I've been practicing for 22 years now. And even before that, when I was doing post-graduation, the only fight I had with my guides was, why do I need to put crowns on all the teeth? Why do I have to use hard materials? And why so much of destructive dentistry? My answer was, please learn what the curriculum teaches you. Once you have finished the minimum possible requirements, then do experiments. So please, I'm not saying don't do what your curriculum teaches you. That has been created and curated for a cause. And don't say college doesn't give me anything, colleges don't teach us anything. they teach you a lot provided you want to imbibe. At least they give you a legal degree without which you cannot practice. So rather than telling the system is wrong, improve your own system. Life is all about upgrading. You cannot say I know everything and stop. I gave you my truth. For me, in my practice, only thing I need is resins. Because the philosophy of life is very simple. The softer I load, the better I have. If I do hard fillings today, they'll break. I'll do root canals, crowns maybe. They break, I'll have to do implants. They are also not eternal, long span of edentulism. But if our restorations are done scientifically, they will last you long. You can transform them to inlays, onlays, maybe much later root canals and crowns. By the time you reach an implant, the average Indian life is set. And no one wants to live more than that. I'm not saying you should not, but till you live, your teeth will be there with you. The practice philosophy that I do my work with is very simple. I cannot please the entire world, so stop thinking that you'll be the most popular dentist. You will be popular if you're popular amongst one and many ones. But if you think one shot 200 people will make me popular, it will not happen. It grows over time. So please, each patient that comes to you, treat them as the most important patient and make sure they are happy. If they are happy, their world is happy, your world will be happy too. It's always a teamwork, and when I say it's a teamwork, one of them is always hanging, but none of them is falling. So this teamwork is the system we live in. As I said, do not blame the system. System has its own problems to deal with. In the college, utilize your seniors, your juniors, your staff, your management's help. You get out of the college, utilize the help of professional organizations, associations. The biggest in the country is which one? Please guess and tell me. Don't guess, you should know about it. It's Indian Dental Association. IDA has been thriving for years to make sure that everyone gets good education. And honestly, today when I'm speaking here, it's a very clear statement. It's absolutely free of cost, no honorarium required. We are doing this for education. Neither do they charge you, nor we charge you. But why did I spend, I could have easily flown back yesterday morning. I finished my work on Saturday. I stayed over a day extra so that we can share and discuss with you absolutely everything which is for your good, not for anyone else's benefit. So if he takes this opportunity, no, clap for the organization, the institution, and if some energy is left, then for me. Because I'm actually not joking, individuals cannot make differences. See, we were born in an era, see, no one has seen God, but at least we have seen something close to God. And that was Sachin Tendulkar. But till God was on the field, India never got a World Cup. He was every time highest century maker, highest scorer, the best records. India never won a World Cup. But imagine all the World Cups that India has won, no one has made centuries. None of them good players who made you win the World Cup were the highest scorers. It's a team effort. I'm not saying don't be good, but with being good, you need still a very good team with you. So when you're out of the institute, enroll with the organizations like these. They help you a lot. And after that, keep upgrading, keep traveling, keep seeing what the world is doing. Because one of my very senior mentors, Dr. Sandesh Mehga, told a very simple statement. The day you realize you know everything, please retire. Because that means you are done with. You have blocked a space for someone who wants to grow. So if you know everything, retire please. And before I end, a very small game for all of you, because yes, I've been speaking for a long time. Obviously, mental slowing happens. Just to revive your gray cells, let's do a very small game. ABCD, everyone knows? At least now say yes or no. This has nothing to do with flexibility and modulus of elasticity. ABCD, this big, right? You were taught. याद है कि भूल गए? सच्ची बताओ. 1, 2, 3, 4. पक्का ना? She's saying, हाँ भाई, क्या पूछ रहे हो? No, why I'm asking you this is because I'm going to give you a very simple trick to treat problems in life. How many of you believe in luck? L-U-C and K, luck. See, it's also very relative. What is the passing percentage of a dental school? 50, right? So your problems have to be your graduation percentage, plus and minus. L-U-C and K. The mathematical aggregation comes to 47. And I for very surely know, if you get 47, you're not given a grace. So would you blame luck for your failing in passing or probably success? You cannot. It doesn't even qualify. Second word is skills. You may be the most skilled person in the world. What's your success percentage? Please read. 82. Knowledge. This is for those people I mean, I'm sorry, but when I say this, who rub the books and they probably swallow it. And not one, many of them. But my question is, do you realize what is the definition of dentistry? Any branch? It is what is the first word? If science was only so important, then why did the guy who gave definition said art and science? Both are important, but science has to flow through your hands. So if art is not good, science will become useless. But even then, both of them are not qualifying. Look at hard work. Because people say intelligence can be compensated by diligence. That's also not 100%. What is 100%? I don't say this. English and mathematics combined tell you this. And what is attitude? Attitude is truthfulness. Till you are here, please learn as much as you can without any bias. And when you go out, accept your mistakes. Choose what you can do the best and excel in that. If you want to be a good doctor who does everything, endo, prosto, perio, pedo, implants, and also read biopsies and also do CBCT readings, I'm so sorry, you will be never successful. Because you were never known by 20 average things you do, you're known by one good thing that you do. So choose that one thing. It's like choose your blue ocean, your blue waters. Choose that and excel in that. But if you want that because my competitor is doing implants, I have to learn it. If your aptitude is not surgical, don't see blood. If you can read colors, if you can craft things, get into restorations. If you can treat kids very well, do pediatrics. And I'm not saying do pediatrics as in do MDS there. Some people may get a chance, some may not. Don't get disheartened. You still can hone your skills in that branch and become a good, popular, successful professional. So before I end, the biggest doubt in life is the biggest answer in life. What and who is your biggest problem? Whenever you're bothered about that, please find a life-size mirror, not a small one, life-size. Stand in front of it. If you cannot tell yourself what is right, no one can. And if you cannot contain and control your wrong, no one can. So you are your biggest problem and you are your biggest solution. First ask yourself that am I right? If your inner voice is yes, you will succeed. But you know you are wrong somewhere, but to show to the world, no, it's all good, it's nice and rosy. Trust me, it's very easy to accept than to deny. And this I have been saying so many times for so many years. Because when I see dentistry, the current generation, the current philosophy of dentistry, not exceeding what we did. Because yesterday me and Dr. Anant were sitting together and he said a very, very nice example. That when you are here at this level and when you fall down, you reach very low. But when you are here and you fall down slightly more, you still have a lot of space to left. So please be here so that even if you fall, you're still safe. If you are here and you fall, bottom. That's the only place to be. So please do not be happy in achieving small goals. Set high goals and achieve them, not small goals and achieve them. Because these are the words from Steve Jobs. I'll just rephrase how I adapt to it. If you want to succeed in life, you first take a decision and then give whatever you have to make it happen. But if you think that decisions will happen on their own, that's what differentiates a successful man from someone who's not succeeding. Leaders versus followers. The only difference is one decided what he wanted to do and second wants him to decide what he should do. So that's how the world is segregated. People who make the decisions and people who wait for decisions. Before I end, again I would like to welcome, inform or probably request you all, if you want to see different aspects of dentistry, learn as many places and people you can learn from. A conference will be in Mumbai, 14th to 16th of November. We have people here who are members for the longest time, who have been working with us, seeing our philosophy. You can take guidances from Dr. Anandpal, Dr. Prabjit is here, Dr. Harleen is here. They're all here to help you. Be connected. That's all I have said. And before I end it, thank you very much for your appreciation. And for so long you've been sitting stable. That's a big achievement. Now you can stand up and move and relax. Any questions, any doubts, even if I have left from here, wherever possibly you can catch me is on the screen. So I do not wish to run away from any responsibilities. I will be there to answer your questions anytime that you want. Thank you very much. Any questions before we do the demonstration? Someone has a question here. Yeah, please. Do you have a mic for him? Or you can come up here and ask the question so that everyone listens to your question. So whoever has a question can please come up here, because a lot of people will have questions, but we have very few representatives for that. So whoever is representing can ask questions. Yeah, please.
Thank you, sir, for your nice presentation. So, sir, I have a question that can we do this in case of root canal treated teeth, especially in case of anteriors and premolars, where there is a suppose 2 or 3 wall breakage, where we need a post. So instead of giving post, can we do this SFDC composite technique?
Okay, the question will be answered in 2 formats. Number 1, if you need a post, you have to give a post. You cannot alternate a post for any other philosophy, because posts are supposed to be given in teeth where you do not have enough material to hold the core. So if a post is indicated, no matter what material I use, I'll have to give a post. Question 2, can I use this on non-vital teeth? Absolutely yes. In fact, what we do is we have very nice, expensive, beautiful composites for vital teeth. And what do we use for non-vital teeth? Whatever useless composites we have or whatever material we have. So it's similarly like someone who's sick is in the general ward and someone who's healthy is in the ICU. Sick teeth means non-vital teeth require more reinforcement even if you're doing an onlay or a crown. So in non-vital teeth you require these materials more than you require them in vital teeth, because fracture potential of non-vital teeth is higher than vital teeth. To stop that, even under a crown you have to use these materials, because a lot of non-vital teeth with crown, don't they break with the tooth? So to avoid that, reinforce the tooth internally first, then you choose crown, onlay or direct restoration. But internal reinforcement is very important.
And sir, another question is that in case of IDS, should we use the thin layer of adhesive layer or we have to go for thick layer adhesive layer?
The thinnest possible. Because when you say IDS, what are you trying to do? Immediate dentine sealing. And what seals the dentine is the adhesive. The thinner the layer, the lesser you will have shrinkage outwards, and the more penetration inwards. The thicker the layer. Now probably your question is, after IDS should we do a resin coat or not? Yeah. To put some flowable. That is acceptable, because if I have some defective margin, I'll use a little fibrafil flow or any chopped fiber flowable, very thin layer to make it even. Because then everything is shrinking. Like I did, I put a fiber first. So how did we do? Bond, cure, fiber, cure, very thin layer of flowable, cure. So that's like a modified IDS also. So you have to put, the bond has to be thinnest, but a very thin layer of flowable after curing the bond. And then you can finish and polish it.
Thank you, sir.
So that's all we had.
Any questions?
I think we're good then. Whatever, as you say. You want demo first? We'll do demo first.
Hello.
So just a yes. Again, before we call this session off, and before, so just a second, I'll just take 2 more seconds from everyone. Before we call it off and before we start doing the demonstration, there's a very small formality I would like to extend from our side, because as I said, we have to be with people who are with you. And I'm so happy that today was made possible because of the efforts of those people. And happily, both of these people are members with us at the Indian Academy of Aesthetic and Cosmetic Dentistry. And this is not for me or them. This is for the entire audience to appreciate the presence of such people who have been associated with us for the longest time. It's not just my organization or your, any organization, because these are the guys who make it happen. I would want to extend a very small token of appreciation, which is like a small certificate, to two of our very senior and oldest members at the Indian Academy of Aesthetic and Cosmetic Dentistry, Dr. Anand Pal Singh and Dr. Prabhjeet Singh Sethi. So I would just request them to come up on the stage. It's just a small token of appreciation. I know we cannot give them anything more than this, but just so that everyone knows that there are people who are concentrating and doing the cause of dentistry. So please give a big round of applause for the people who have been associated with us. You saw the 3 people hanging? I'm always hanging in between. Honestly, I'm the one who's hanging. These are the guys who are saving me. And I would be very happy if next time when I come here, I have to carry a whole bunch of more certificates. So that I can give it to all of you as members of the Indian Academy of Aesthetic and Cosmetic Dentistry. Thank you very much. Certificate. Now, sir, all yours. Demo hai na?
Thank you so much, sir. Your lecture was indeed insightful and thought-provoking. I request a few moments of patience from our audience as we prepare for the demonstration. Thank you.
or a rounded instrument, you can just, whichever area you want to spread it, you can spread it. It's a stretchable mesh. If you've cut less, you can always elongate it. The little drop of flowable that we had put also ensures that there is complete wetting of the surface and there is no gap. It's completely gone through and through. Once you've done it, you will light cure it. Always remember, irrespective of what company you're using, anything which is fiber-based composites has to be cured for more time. So if regular composites are 20 seconds, this should be 30 seconds. Once you have cured it, you will just take the same flow and just cover the exposed surfaces of the fiber with it. Very thin layers. We are not doing very thick layers. Just spread it across the entire surface so that your fiber doesn't come under direct load of any sorts, and you will light cure it. If you remember, we talked about something called as reinforcement of that weakened cusp. So which cusp was weak in this particular model? The distolingual cusp here. Remember, it was very weak, even less than 1 mm. So how do we reinforce it now? We have two options. One, I keep on adding small amount of flowables and this fiber 2, 3, 4 times. Second is I use a more convenient product which is called as the FibraFill cube. Now this comes as a blister pack of 4 cubes. You just have to open the sticker. The cube is inside. Don't make the mistake of holding with a tweezer and pulling it off. Don't make that mistake. Use any clean instrument and just scoop it out like an ice cream scoop. Again, they're all pre-adhesed, they are sticky, they will not fall. I want to reinforce this hollow area here. See, I want to reinforce this hollow area here. So I'll get my cube into that area. See, the cube is there. You put it in whichever orientation you want. Right now, I want it to be obliquely placed so that it goes into that weakened cusp. I'll place it there and I'll gently tap it into my weakened anatomy so that it takes the shape of that weak cusp. How do I know I have to stop at what level or can I go deeper? There's an instrument here which I have. If you see, the instrument has a tip. This tip is 2.5 mm. The moment I will put this to the occlusal surface and I'll move it, I'll know I have enough depth. If it's touching, let's say, if it's touching, means it's more. So you'll have to push it down. If it's not touching, means you have left absolute equal enamel depth everywhere. So I'm just going to pack it inside that defect. Now please remember, how much was the thickness of the enamel wall here? Barely 1 mm. That means, do we have any dentine left? Maybe none. So if I want to cure from the outer side, I'm only utilizing the translucency of enamel. See, it's going to shine through. Where will it shrink now? Even if it's dentine, even if it's flexible, everything is right, it shrinks towards the light, and light is shrinking towards the cusp. Then you can just go on the top and cure it again for 10 seconds. This layer is cured. So we've decoupled the pulp, we've covered the fiber, we've reinforced the weak cusps. Now we need to build the base. Bio base. I have two options. I can go back with my same FibraFill flow, or I have another product here which is same dentine, which is called as FibraFill dentine. It's like a compule. You just need a dispensing gun for it. So you already saw the flow, so I'm just using the FibraFill dentine for purpose of showing you. Both can be used, flow and dentine both. So you just inject it softly. It's a very soft material. You can control the flow, you can target the area where you want to inject. And again, with a clean instrument with very soft hands, you can just blend it. You can also use clean brushes like these, bonding brushes, or special brushes which are available for adaptation. But they have to be clean and the bristles should be very stable so that they do not get embedded into the matrix. Once I have filled my entire base, I will light cure it. Again 30 seconds, my base is ready. Now there are just two things left. Recreate my DEJ and my enamel. So what goes at the DJ again? The same fiber. But this time it will not be that big, it will be slightly smaller because my table of restoration has become smaller now. So I'll get a small bit of this. Please put it back. And the rule is still the same. What do I need underneath this to make sure it wets nicely? 1 drop of a flow. So I put 1 drop of a flow. I take my fiber into the dentinal area to now recreate the DEJ. Whichever orientation you want, you can spread it to that orientation. Here I am spreading it through and through. It's nicely adapted. Please make sure all the fibers are within your tooth confines. It should not come out occlusally, it should not come out proximally, buccally or lingually, and you light cure it. Our bio base is complete. Now all we have to do is recreate the enamel. Please remember, when you have to do the enamel, never do the entire tooth together. And remember 2 terms that were taught to you in prosthodontics, the curve of Spee and the curve of Wilson. What does Spee tell you? Follow the line of central grooves so that you do not go too much buccally or lingually. What does Wilson tell you? The cuspal heights need to be uniform. That gives you an angle of how much you have to build your cusp. The 2 sets of composites I have here, you can use either of the 2. So these are all enamel composites that you have. You can use either of them. Any enamel that you have in the market, any universal composite you have in the market, you could use. You have them in tubes, you also have them in compules. I prefer compules because my material saving is more and I don't contaminate. So all I do is I load my compule here and I'll go cusp by cusp. The rule is start with the difficult most cusps first. So I'm going to adapt on my bigger cusp first. Again, with any flat instrument, I'll just dump it on my anatomy. And now we can create our groove pattern. So you can use a beaver tail instrument like this and just nicely adapt it to the tooth towards the slope of the cusps. Please keep on marking your slope so that you don't do excess. And now where do I cure it from? Not from the top. We need to go trans enamel. So first you'll go trans enamel for 20 seconds, then on the top for 10 seconds. This will make sure the shrinkage is happening towards the tooth, not towards the core. Similarly, the second cusp. Please remove whatever excess you have, remove it right away. Don't wait for your cutting and polishing to remove it, because the lesser you touch your restoration with the air rotor, the stronger your restorations are. So you can use these instruments to cleave off the excess. Cure again trans enamel first. Once it's cured for 20 seconds, 10 seconds on the top. See, I've done 2 lingual cusps. Now I'll go to the buccal side. Good part about compule based materials dispensing is you exactly know how much you want. Because when you're putting, you're actually seeing where it's going. Please blend all surfaces nicely so that there is very little excess for you to trim later. So if you notice on the surface, I have done the entire mesiobuccal cusp, but I have left this triangular fossa intact. I haven't filled it right now. Because if you fill it, chances of going wrong on the anatomy becomes very high. We'll do the both fossas absolutely at the end. So the same philosophy, 20 and 10, 20 in transenamel, 10 from the top. I'm going to my last cusp now, which I have to build up completely. So more material. Adapt more material so that you get the right height. This is where these compule-based composites give you a lot of ease to work in terms of dispensing your material. My fourth cusp is also done, and if you notice, the only time that I am saving here is in the curing, probably 2 minutes or 3 minutes. Rest, everything is happening as it happens on the patient. But the best part is on the patient, I don't have to talk and give a commentary, so I can be faster. So it takes almost the same time on a patient to do this process. Again, through the cusp first, then from the top. Now all I have to do is just do 2 small triangular fossas and we are through. First fossa is done. Light cure, I'll go to the second side and our adaptation work is finished. Now all we need to do is put the oxygen inhibiting gel, wait for 15 minutes and start your finishing and polishing. So if you see, we can just in a very simple manner recreate the entire occlusal anatomy. I'm not saying because it's fast you should do it, but if you do it, your work will become faster. Because you're doing very controlled application of layers, you're not doing bulk application of layers. Now once this is done, all you need to do is apply a layer of clear glycerine on top of it, light cure it again. So this is clear glycerine. Thankfully I have it. So this is clear glycerine. This is a commercial product. You can buy it off the counter. Even a KY jelly would do. But no Vaseline, please, because Vaseline has resin residues. So let's presume our restoration is done. I'm going to just apply this glycerine gel on top. See, the entire thing is shiny. Please spread it to wherever you have your composite and you will light cure it again. Same time that you cure your last layers, 20 seconds. Let's say I've done a buccal extension, so I'll also do buccally 20 or occlusally 20. If you've done proximal cavities, you will cure through the embrasures like this, so that all uncured areas get the light cure. And that completes your restoration. After that, 15 minutes finishing, a day or two polishing. There's a request which came during the break, so I'll just very quickly demonstrate it. Now we are talking everything which is till the base of the tooth. But what if it's a non-vital tooth? We also had a question during the discussion that in non-vital tooth, what do you do? So till now we were either doing custom cast posts or prefabricated posts. The biggest challenge for both these things is you have to make a post space. So no matter how much of pericervical dentine you have saved during your process, the moment you make a post space, you use a drill and the drill destructs the pericervical dentine. What if you have a post in which you don't have to drill? Because all of us are doing tapered endodontics, 4%, 6%, etc. What if the post fits into your pre-existing space? So no more dentine destruction. The answer to that is pin posts. Now these are posts which are available in the form of very thin pins. The diameter of each pin is 0.45 millimeters. So a very logical question to me should be that my post gives core retention by the virtue of surface area. And now you're telling surface area for my post, which is, let's say 1.2 mm, you're telling use 0.45. So now let me answer this question. If I'm doing a big anterior tooth, if I put 3 or 4 of these posts, what is the surface area I've achieved? 0.45 into 4, which is 1.80. If I'm doing a posterior tooth, how many posts can you place in a posterior molar or a upper or lower molar? Maximum 1. That too in the biggest root. After drilling, what if I tell you don't drill, utilize or fold canals and place 4 posts? Your surface area becomes much higher than a single post, plus stress distribution is very good. Because these posts are slim and they are flexible, they can even get into the curved areas of your tooth. So if you notice, look at how flexible this post is. I can actually play with like a slide. See? Flexibility. I can insert it into even curved canals, which is a very big indication, contraindication for bolt posts. So I've just kept 2-3 posts here. So I'm just quickly going to do a core demonstration, post and core, on a prefabricated plastic model. So this is my plastic model which I have. There's a core space, post space already done. Okay, what are the philosophies of utilizing your cements inside the post space? One is you can etch and bond. For that you need a self-cure activator. The second is you can use a self-etch adhesive. So cements like these, bioactive cements or things like Calibra Ceram, Calibra Universal, not Ceram, Calibra Universal or Corex Flow, Fluorocore, etc., which are available, Paracore, which is available, they're all dual cure. They also come with their own bonding systems. So either one which comes with its own bonding or something which is totally self-etch. I'm going to use a T matrix here. It's a very simple kind of a matrix which doesn't require a lot of retainers. It's a T band. And this also is available in India. You can check it on, I think, Dental Cart, you will find it. Till Pulp gets it back. All you have to do is just engage into the tooth and just tighten it. So you have a retainer-less matrice. You don't have to use a retainer. You can cut the excess. Now, presuming I have applied the bonding agent on my tooth, if it's a self-etch adhesive, your bond will only go into the coronal area, not in the radicular area. In radicular area, you will only apply the bond if you have a 2-bottle dual cure activating system. If it's a purely light cure system, you cannot go inside the root like this. Light will not penetrate, your bond will fail. So you'll apply the bond only on the core and the periphery of your orifice. Light cure it. 20 seconds. Now I am ready to insert my post. Now because this is a long post space, I am going to use the full post length. But good part is this post is 20 mm in length. Now imagine you have a canal which has 3 canals, a molar which has 3 canals. You can cut this into 7, 7 and 6. And each of them needs to go in a multi-rooted tooth 4 to 5 mm into the canal, 2 to 3 mm outside. So one pin is going to give you 3 post space retentions, economical and scientific. But for longer root lengths, you have to put longer ones. Scientifically, it has been proven, you can check the research. Post retention has nothing to do with length now. It was only viable when we were cementing posts. Now we are bonding posts. So 4 to 7 mm is maximum that you want to go. So if I have cut 5 mm in each canal by a downpack device or an electronic plugger, I can use one pin for 3 canals maybe. So I'm going to use a bioactive cement or maybe a self-adhesive cement. Please note the difference in the 2 diameters of the cannulas. If you notice, the one which has to go into the root is small, the one which has to go into the core is huge. Don't take the bigger cannula inside the root, you will have air voids. For roots, you should have thin cannulas, preferably something which you can bend to a long distance. You do not need to put any surface treatment on these posts because they are pre-adhesed. So no applying bonding agent, no applying silane, nothing. Self-etch adhesive cement, bang in the post. So I'm going to put my self-etch cement inside. Just make sure I filled the orifice only till the head of the canal. I have not filled the entire canal. Whatever little cement is left on your tips, you cannot waste it, you will utilize it. So just gently coat a little, and with very soft hands, without creating too much of a stress, slowly insert the first post till it hits my bottom. Second. You just have to push it very gently, don't have to push it very fast and hard. The third. This is like lateral compaction. You can place in as many as you have, and please charge for as many pins that you've placed. The best part is, once you have placed these pins, you can actually decide the orientation of force. If I have an oval canal, I can spread them along the oval canal. If I have a round canal, I can make them like a small bouquet inside the round canal. And once I am sure, I'll go ahead and I'll cure them from the top. Now, because this is glass, the transmission of light is 100%. Even in glass fiber posts, transmission is about 47%. Why? Because of the angulation that they have when the fibers are cut. They start with a lot of fibers on the top and they end up with very little number of fibers at the base. So light transmission is little. Metal has zero transmission. So if you want to use light curable cements, these are 100% post light transmitting posts that we have. So here I am not being a miser, I have to cure for 20 seconds. Not even for a demonstration, I can reduce the light curing time because I have to take these out and show it to you, how they adapt to the core. So these post and core systems can be also termed as anatomic or adaptive. Because when you put them, the cement takes the shape of the canal and they push the cement to the core. So let's say I've done this post now. Now I have to build up a core. I can use any core build-up material available in the market. These are all dual cure materials. Where do I use this versus where do I use, let's say, a fibrafill for a core build-up? If I have a very clear axis, very nominal axis, and I have to give an onlay or an overlay, this works. But if I have destructed tooth structure, even these core materials are going to be brittle, they will break the tooth. Then you need dentine replacements only. I'm just going to build a quick core with this. Just use an instrument, keep on removing whatever is excess right away so that you don't need to cut it later. And light cure. Only remember the role of dual cure materials is, they cannot be purely light curable because dual cure means it cures with light and heat, auto curing both. If I have a light cure material which says it's bulk, light cannot penetrate beyond 2 to 3 mm. Then how is the bulk curing at the base? So if you want to use bulk fill philosophies, you have to use dual cure materials or triple cure materials. You cannot use purely light based materials. So what you can do best is use dentine in layers like fibrafill flow, fibrafill cube, fibrafill dentine like I did, and then layer it with enamel. So let's say we have done a post and core. I will just remove my band. And let's see whether I can remove it because I have not put a bonding agent. If I am able to remove it, just to show you how the adaptation has happened, if possible, which is, please don't try this on your patients to see whether it's adapted or not because you cannot, it's already bonded. Please look how it's taken the shape of the entire core. Absolutely adaptive. I did not know what the shape of my root is like, but if I use this, it will take the shape. Otherwise, what do I have to do? I have to create a shape to put a post. It's like because I have to do some work, I have to destruct my tooth. Here, whatever the tooth is, I have exactly given the post shape. That also helps in stress distribution. And to see the strength, strong. So it's not a weak material. Just because it looked very thin, it's not a weak material. All these thin materials post bonding become super strong, double strong. So this was all about post and core. That's all I had to show. Any questions? Can we have the lights? For post space, you just remove the gutta percha with an electronic plugger. If you don't have it, the minimal most invasive drill you have in your practice, you can use that. Number one, the Largo, which we call the Largo drill. So are we done? Wait, just a very small thing is left. Journal. So you can have a look, you can circulate that post and core, it doesn't look weak at all. And whoever wishes to break it, please try this. Now I want you to break it but separate it into two halves. Like fractures happen on teeth. They separate, right? Try and separate this. One pin has more than about 10,000 fibers in it. So if you want to break 10,000 fibers, you'll have to keep on breaking each one individually. Even if half of them break under load, still 5,000 is left. And if I put 3 pins, 30,000 fibers slots in a tooth. Try and eat whatever you want to break it into two halves. It's very difficult. So before I leave, I would want to present the journal that our organization has to the senior people and faculty in this room. Sir, Principal sir, I think he's not here. I'll give him in the room only. So sir, this is a journal association of aesthetic dentistry journal. And I would request everyone to try and send cases so that we can publish. Sir, please. So that we can make sure that everyone gets recognition that they deserve to. Dr. Raju. Sir. So the strength, when we talk about strength, we always think about fracture toughness. Yes, but now here the concept is not fracture toughness, it's the resilience. So what is easier to break, a rigid thing or a soft thing? The rigid one, right? All those ones are very rigid, so they break very easily. This one is like flexible, so whenever they loads, it will bend, and when you release the load, it will come back. Rigid posts, what happens when you have force, they will bend. But when you release the force, they still bend. So there are more forces, and it breaks. This one is bend and back. That's why if you notice, modulus of elasticity of this post is 18.6 GPa, which is exactly same as dentine, sir. 4 to 5 mm, that's it. And 2 to 3 mm on top.
And the restoration is just top on that, which is the core. You want that core to be totally submerged.
Yes. So the idea of core is the core should be 3 mm below your occlusion. This should be 3 mm above the occlusion, the core should be 3 mm above the occlusion. So you can still have 2-3 mm of material without the post. So from the orifice, let's say 3 mm is the post, isme material aa gaya. From this level, another 2-3 mm can be just your restorative material. So the post doesn't have to come all the way. In fact, the rule of a post is it should never be exposed to the occlusal stress.
This discussion can go on in lunch also, right? We all are going to the fifth floor.
So I'll just this one you have to remove it with the scissor. Any scissor, but clean scissors.
Thank you, sir, for your meticulous demonstration. This brings us to an end of the lecture and demonstration session. No. Participants, please collect your certificates from outside the hall. And participants for our hands-on workshop, the workshop will commence post-lunch in the room opposite the auditorium. Thank you. Once again, I thank everyone for participating in this program. Thank you.